And I, Angsuman, we welcome you all to the 12th RSSDI Annual Conference, State of Odisha.
We have invited faculties from all over the India, chairpersons, eminent speakers, and office bearers from RSSDI, Association of Physicians of India, API, Endocrine Society of India, ESI, and Indian Medical Association, IMA.
Their active participation in various sectors and workshops will make this event a grand success by taking home the message, let's de-diabetes India.
Moving further, let's invite the personages of this momentous occasion onto the stage. Now, I'd like to request Professor Dr. Jayant Kumar Panda, Chairman, RSSDI, ODISHA, to join us on the dais. Sir, please.
I would like to invite Professor Dr. Sambit Das, Secretary, RSSDI Odisha, onto the dais.
Now let's welcome Professor Dr. Ramesh Kumar Goenka, Chairman-elect, RSSDI Odisha.
Progressing forward, we would like to invite Professor Dr. Santosh Kumar Swai, Organizing Secretary, RSSDI Odisha.
Next, I would like to invite Professor Dr. Hariballabh Mahapatra, Co-Organizing Secretary, RSSDI Odisha.
Next, we would like to invite our chief guest of this scientific inauguration, Professor Dr. Niranjan Tripathi, President, Odisha Hematology.
Next, we send our cordial invitation to our guest, Professor Dr. Balmurugan, Director, Kovai Diabetes Institute, Coimbatore. We welcome you, sir.
Now, we would like to hand over the mic to Professor Dr. Jayant Kumar Panda, Chairman, RSSDI.
Over to you, sir. Thank you.
Thank you, Anshuman. Thank you, Asha Jyoti. It's a pleasure again welcoming you all. And we had a fantastic workshop and CME pre-conference yesterday. And the footfall was more than 300. You'll be happy to know. And with this, the day begins with the scientific program. And this is scientific inauguration. I'm very happy that our registration touches 700 and we have around 200 accompanying persons, faculties, organizing committee, all total crossing 1,000 people, 1,000 footfall of the event. I'm sure very soon the hall will be full and we'll have plenary sessions in full phase. So I congratulate Dr. Goenka for a beautiful scientific update. I congratulate Dr. Shambit for the beautiful coordination of the organization and Professor Santosh for executing, running from pillar to post and executing such a huge mammoth conference in the holy land of Puri. I invite Professor Tripathi, who has stood every time with us. He is a past chairman RSSDI and at present the president of Hematology Odisha, and always he has come encouraged. And we have Dr. Balmurugan, who is the director of Kovai Diabetes Center, Coimbatore, who is a prominent national figure in the field. So with this, I request Dr. Goenka to say a few words.
The scientific update has been designed beautifully with the help of our chairman, Professor Jayant Panda. I want a big round of applause for Dr. Jayant Panda for this beautiful endeavor in helping us to design such a beautiful program and which has attracted so many delegates. And now it's really difficult to accommodate few more which requests are coming at the last moment. And I hope next 2 days you are all going to enjoy the beautiful scientific feast over next 1.5 days. Thank you.
Thank you, Professor Goenka. And you'll be happy to know that Professor Goenka and Dr. Dabas
Thank you, sir. A very warm welcome everyone to the temple city of Puri, and the scientific program has been nicely crafted, and I echo the same that Jain sir has done a mammoth task, and hope for the next 2 days you will enjoy the scientific fest. Thank you all.
So, with this, I request our guest to say a few words and declare the program open. To start with, Dr. Balamurugan, our invited guest from Coimbatore.
Good morning, everyone, and thank you, Professor Jayant Panta, sir, for these wonderful arrangements and the scientific feast. And I congratulate you and best wishes to you. And I thank Panda sir and the scientific committee for asking me to come here and to enjoy these sessions with you. Thank you.
Professor Tripathi is teacher of teachers and an inspiration for all of us. So he is the chief guest for the scientific program inauguration. So finally, by giving his blessings of chanting a shloka for Lord Jagannath, we are in the land of Lord Jagannath, will declare the scientific program open. Professor Tripathi.
Let us all say in very loud voice, Jai Jagannath. Jai Jagannath. Many times, 3 times. Jai Jagannath. More louder. Jai Jagannath. This is Nilachal Dham, and this is the place in India which is the holiest of the holy. And Jayant, by choosing this place and his scientific partners and you all, you have blessed yourself, because the Lord is just blessing all through for this conference. This is the largest conference organized in Odisha at a state level. Nowhere in state level conference more than 1,000 footfalls do come. Created in 1973, RSSDI is the largest scientific organization in Southeast Asia and in the world, only next to the Federation of Diabetes. So please applaud that this is the organization which has created history in India and made diabetes so aware that people are now having diabetes. And in spite of diabetes, when it was diagnosed, people are dying within 3 to 5 years. They are now living 100 years. And I am 85. I am only one of those diabetics. For that we must pray Lord Jagannath. There is a very, very beautiful sloka in name of Lord Jagannath. You, those who know, you please sing with me. Shishir bolo. Niladro songs. Those who can stand, please stand up. Those who can sit, they can sit. Because this is the Lord's prayer. Those who believe, they stand. Those who do not believe, they can sit. Because the Lord is everywhere. He simply forgives everybody for every sin and every punya. So naturally, our Lord is extremely powerful and extremely forgiving. Niladro sankha madhye satya bolna satadala kamale ratna singhasanasthang nila bolo sab are ma bolnu niladro sankha madhye satadala kamale ratna singhasanasthang sarvalankara jutang navaghana ruchirang chagrajayena sanjutam Bamaya Bam Bhadraya Bam Bhage Rathacharana Jute Brahma Rudrendra Vandyam Vedanang Saramesang Swajana Paribrutang Brahmadaru Smarami. This is a sloka which describes this is the only wooden god in the world, only wooden god who recreates himself every 12 years. And having a Brahma. This is the God who takes care of his body every week. Every week he makes a facial for himself. Do you know it? Jagannath makes a facial. Rabi janicho? Bonno kalagi. Bonno kalagi. Jagannath is the most colorful God in the world. Every day, he just wears 6 new dresses. Every day, he takes the largest amount of food and distribute amongst the people, where nobody is given that amount of food. Any slight disorder, all the foods are destroyed. He is the Lord who spends about 10 crores to buy a car and uses for 7 days and throws it. No God or no Lord or no king has that power. And this slok says that he is standing on the top of the hills and he is a family man, just like RSDI members. You see, you are all coming with a family, and those who are not coming with a family, they make here everybody, they are family men, like Surendra, like Shishir, like Prakash, like Sheva. They make everybody, embrace everybody, give love, love, and love. And Lord Jagannath is God of love. And he is up. And do you know, Jayanta in his WhatsApp tale, there is a line for in his below his WhatsApp name. Have you anybody read it? Jayanta's WhatsApp, anybody read it? No. He's, क्या लिखा है? No. He simply tells love. Love. Love in thought, word, and action, which Lord Jagannath proposes and distributes and also gives every time, everywhere, free of cost to everybody. So, he has a truly Odia Asmita man, Jayanta. He took the Jagannath words and told his own name, love, in everything you do. So he has loved this conference. He loves organizing conference, and he has made conferences in Odisha, which will be memorable by everybody, those who visit. Balababu is there. Yes. He made in 17 conference, #1 conference in India. Till the people are thinking that type of bag, that type of gift, that type of food, that type of distribution cannot be replicated. So friends, if anybody doesn't come prepared, he can talk on like anything. So with this, I finish.
Thank you, sir. Thank you, guests. We are almost half an hour late for the program. And I wish that all of us will have good science, good food, good fellowship, and the next 1.5 days will be memorable. I thank our guests. I thank all the organizing committee and everyone, and request Santosh to formally extend a vote of thanks, and we'll start the scientific program.
My respected delegates and faculties, I welcome you to this holy land of Puri for a academic fest. Our motto is, let's de-diabetes India. So, on that motto, we can carry our journey from the beginning of this conference. Thank you all.
So with this, by our guest, the conference is declared open. The scientific program is open, and at around 1 or 12:30, we'll have a formal inaugural function where our guests will be joining. So directly we'll go to the scientific program. Thank you, sir.
Thank you, sir. Thank you for the honor.
You have taken the names of the chairpersons? Come.
Without further delay, we would like to start our scientific session. And I'd like to request the chairpersons of the scientific session Dr. B.N. Panda, Senior Physician, Bhubaneswar, and Dr. R.N. Kara, Senior Physician, Bhubaneswar. I request the chairpersons to please take their seats on the dais and carry forward the program. Sir, please.
Jai Jagannath. After the galaxy of the scientific mind taking part in inauguration, we are there to start the first scientific session with topics like SGLT2 inhibitors that have not only revolutionized diabetic treatment but also encroach into cardiac domain, and problems of diabetes in the young, which is type 1, type 2 or any different type. And third, impact of postprandial hypoglycemia. For this, we are eminent speaker, Dr. Goenka, the chairman, Dr. Alok Kanungo, one of the established diabetologists of the state, and Dr. R. Balasubramanian.
Welcome all of you to this morning session. Proud to chair in a hall whose name is Professor B. V. Tripathi. I am very fortunate to be a close and student. I want to, it forced me to tell a few words about Professor Tripathi, how sincere he was. At 2 o'clock he will have a lunch in the train, bringing in a small container, and after finishing the lunch in his room he will invite to the library, and personally he will find out literature for us to discuss in the postgraduate. How many professors are out now doing this, I doubt. Again, he is the only professor I have seen always encourage any doubt. You can come to my house even the odd hour to get clarification. So much so was sincere a professor I have heard of anybody after that. Anyway, with that, we will start right now the session. I think the first topic is SGLT2 inhibitor and their combination as first-line agent for metabolic care. I invite our Professor Ramesh Goenka, Bhubaneswar, to talk on the topic.
Thank you, sir, for the kind words. This is today's topic. You see that SGLT2 inhibitors and their combinations as first-line agents. This is the change we have seen over last few decades. When we started our practice, we never thought of a second-line drug beyond sulfonylurea, which has gone to the last in the scenario. So how that has changed, what are the evidences we have, in next 10 minutes we are going to discuss. So to outline complex nature of the diabetes management and unmet needs, DPP-4 as a cornerstone in type 2 diabetes therapy, SGLT2 as a pillar in the management of diabetes and complications, double and triple benefits of the dual combinations and triple combinations, and near future need for early treatment intensification by combination therapy. That start early with a combination, not monotherapy, then adding second, then adding third, directly starting with a combination therapy. So diabetes, you know, is a global emergency. Already everybody know this slide, about 537 million all over world, and projected to become 783 by 2045. Type 2 diabetes, you know, is a progressive and complex disease. A 5-year increase in diabetes duration was associated with an excess risk of about 20% of each of the endpoint of cardiovascular disease, myocardial infarction, and stroke. ADA standard of care, a comprehensive approach to reduction of diabetes complication. If you see this diagram, the roots, the foundation is lifestyle modification and diabetic education. And along with that, you have to do a glycemic management, blood pressure management, lipid management, and you must use the agents irrespective of the glycemia. You must use the agents with cardiovascular and renal protection. And all this together is going to reduce the diabetes complications. So what are the unmet needs? The need for a combinatorial approach to address multiple pathophysiological mechanisms of hyperglycemia, treatment that provides glycemic and non-glycemic benefit, reducing the occurrence of hypoglycemia and weight gain, and improves the compliance or adherence to the treatment by the patients. So SGLT2 inhibitors, already described as a pillar in the management of type 2 diabetes. If you see the pleiotropic effect of SGLT2, the effect on the heart is reduction of arrhythmias, reduction of intravascular calcium overload, reduction of preload in terms of interstitial volume and intravascular volume, which in turn increases serum albumin, reduces arterial hypertension, and reduces peripheral and pulmonary edema. In kidneys, you find that there is increase in blood magnesium, and there is enhanced glycosuria, diminished interstitial kidney fibrosis, leading to erythropoietin-producing cells and increase in hematocrit. On blood vessels, they increase vasodilation, and metabolic effect, they reduce epicardial fat, reduce ketone bodies, and reduce uric acid, thereby inhibits RAS mechanism. So SGLT2 inhibitors, the advantage is they induce intermediate weight loss in type 2 diabetes. Their role in the management of NAFLD is already established, and a few more trials are going on. If you see NAFLD benefits in type 2 diabetes, the first molecule is GLP-1 analog, and then SGLT2 inhibitors. Glucose-lowering medications in CKD, if you describe, the first one is metformin, up to 30 milligram of GFR, 30 ml of GFR you can use, and then comes SGLT2 inhibitors with all sorts of benefit in CKD patients. KDIGO 2022 has recommended SGLT2 inhibitors as first-line drug therapy in type 2 diabetes. So SGLT2 eventually has emerged as a surprise in the management of diabetes and its complications. So by its unique insulin-independent mode of action and cardiorenal benefits. Past few years, you have seen that dapagliflozin use has increased like anything in both diabetes and non-diabetic subjects after it has become generic, off-patent, and available widely. So the use has become extensive since 2020. And 2022, the combination of dapagliflozin and sitagliptin has been launched, which has revolutionized the type 2 diabetes drug therapy. If you see about dapagliflozin, the largest evidence in non-established ASCVD risk patients, if you see the normal patients, the lower one, the box, red box you see, that the patient who has no established CVD risk, in them also there is reduction in CVD, cardiovascular disease, heart failure hospitalization, and renal benefits are observed. The effect of dapagliflozin on worsening heart failure and CV death was consistent across all subgroups in DAPA heart failure study. DAPA heart failure study, these are subgroup data. If you see all the groups, all 9 groups, everywhere you find the benefit. DAPA CKD trial, these are the end results, that there is average 39% risk reduction with an NNT of 19. So the unmet needs, do we need this combination? What are the benefits? It acts on multiple pathophysiological mechanisms. It provides both glycemic and non-glycemic benefits. It reduces the occurrence of hypoglycemia or weight gain. The OAD options that not only meets all the needs, but additionally improves the compliance by the patient. patients adhere to your treatment and not defaulting the drugs. So SGLT2 inhibitors, DPP4 inhibitors combination, what are the benefits? If you see, they have a complementary mechanism of action. By increasing glycosuria, they exert an indirect pancreatic effect by increasing beta cell sensitivity and improved insulin secretion and increased glucagon secretion, which this increased glucagon secretion is counteracted by DPP4 inhibitors, and insulin secretion is again stimulated directly by increased GLP-1. The overall effect is reduction in hyperglycemia with a pleiotropic effect of cardiorenal benefit. This is the efficacy of dapagliflozin as add-on to sitagliptin. If you see the patients with ongoing sitagliptin, if you add dapagliflozin, there is additional 0.5% HbA1c reduction with dapagliflozin. This is AAC comprehensive type 2 diabetes management algorithm. If you see the first two columns, the recommendation in overweight obesity patients and those patients who are sensitive to hypoglycemia, they all are recommended to have SGLT2 inhibitors as first line after GLP-1. If the patient cannot afford or not willing for GLP-1 inhibitors, then SGLT2 is the only option for them. This is an expert opinion paper which has said that this combination, it is important to address the multiple pathophysiological aspects underlying type 2 diabetes. Hence, combination therapy with DPP4 inhibitor and SGLT2 may be relevant for such patients. This therapeutic combination may be patient partner to metformin, pertinent partner to metformin in providing meaningful glycemia control without increasing risk of hypoglycemia. The combination of this agent with proven benefit may be preferred for patients with higher predisposition to cardiovascular events and renal disease. And overall, there is increased compliance with the use of this combination. So SGLT2 and DPP4 FDC is a suitable option for Indian type 2 diabetic patients because it provides safer, rapid, and sustained glycemic control. It improves both insulin resistance and beta cell function, help to reduce body weight and blood pressure by exerting extra glycemic benefits of cardiorenal, reduces the pill burden, hence increases compliance, and overall becomes very much cost effective. Effect of SGLT2 DPP4 combination in GI tract infection. If you use the combination versus if you use SGLT2 alone, you reduce the incidences of GI tract infection. So what are the patient profile for initiating this combination? The patient profile is based on first the CV risk, SGLT2 inhibitor and DPP4 inhibitors. You must choose a cardio-safe, those who are having CVOT. So sitagliptin, you know, has a big CVOT, and among DPP4, dapagliflozin has the maximum number of CVOTs. As per the renal data, so as per the renal risk, those who are having CKD or nephropathy, you must start with SGLT2 inhibitor and choose DPP4 inhibitor, which has a renal safety in terms of sitagliptin and linagliptin. Depending on glycemic factors, you must choose your patients. For the management of type 2 diabetes, initiate with lifestyle modification. And then you have three scenarios. If the patient is drug naive, you can start metformin, but where metformin is contraindicated or not tolerated, you can directly start this combination. In the treatment naive patient, if HbA1c is more than 9, then along with metformin, you can start this combination. And those who are uncontrolled on metformin therapy, already on metformin therapy, you can add this combination if HbA1c is more than 8.5%. This is pharmacological approaches to glycemic treatment, standard of care in diabetes 2023. They say that early combination therapy can be considered in some individual at treatment initiation to extend the time to treatment failure. Verified trial has conclusively demonstrated that initial combination therapy is superior to sequential addition for extending both primary and secondary OHA failure. The initial combination therapy should be considered in people with HbA1c more than 1.5% above the target. The treatment intensification reflects a tailoring of regimen in alignment with person-centered treatment goals. This is again AAC algorithm 2023. As per complication-centric approach, if you see lifestyle intervention and followed by independent of glycemic status, you must choose if the patient is having ASCVD or high risk for ASCVD, you must choose a GLP-1 analog. If not, then SGLT2 inhibitors. If the patient has a risk for heart failure, you must choose a SGLT2 inhibitor first and then other drugs. If the patient is sensitive for stroke, give GLP-1 analog or pioglitazone. And if the patient has CKD risk diagnosed during nephropathy or CKD, then you must start with SGLT2 first, and then you can use a GLP-1 analog. So what is the next? You decide the patient's glycemic target, and if not on target, add metformin, and subsequently add the other molecules which are not being used. So the dapagliflozin sitagliptin rationale for early initiation of therapy. The advantages of dapagliflozin and sitagliptin, if you see, rapid and sustained glycemic control achieved, target HbA1c is reached faster, the improvement in insulin resistance and adiposity, decrease in metabolic and vascular risk, they are safe and simply better adherence and improving compliance. This is DAPSI study initially exerted with this combination, which has shown up to 1.7% HbA1c reduction in 12 weeks duration. FDC of this dual FDC has improvement in various glycemic parameters in terms of average daily glucose, the time in target, and time above target. All the parameters are improved with the use of this combination. So, if you see, this European Heart Association has nomenclated this SGLT2 inhibitors as a new statin. So, a statin of 2021, if you see, SGLT2 inhibitors are placed, and they say use it unless not contraindicated. Irrespective of the glycemic target, you must use this molecule irrespective of the glycemic control. So see the Brownwald corner, they have told that SGLT2 inhibitors, the statin of 21st century. They have, what is the position of statin you know in cardiovascular disease, the same status is bestowed to this dapagliflozin. You see the spectrum of disease and beyond. If you see spectrum of glycemic control, in all the spectrum, newly diagnosed, uncontrolled, addition to insulin, irrespective of age, independent of HbA1c, hypoglycemia risk patient, and long duration of diabetes, everywhere you can place this molecule. As in the spectrum of CV disease, diabetes with hypertension, diabetes with dyslipidemia, diabetes with obesity, diabetes with smoking, diabetes with previous MI, diabetes with high severe risk, heart failure with diabetes, heart failure without diabetes, everywhere you can place this molecule. And spectrum of kidney disease, type 2 diabetes, CKD and heart failure, type 2 diabetes with macroalbuminuria, type 2 diabetes with microalbuminuria, CKD without diabetes, and rapidly declining EGFR. Everywhere you can place, this molecule finds a place. So SGLT, now next few slides about triple combinations. You know the advantage of triple combination, they target 7 out of 8 components of pathophysiological pathways of ominous octet and facilitate treat early and treat tight approach. So early intensive therapy with this triple combination has proven benefits in improving glycemia, in reducing adiposity, reduction of metabolic and vascular risk, simplicity for sustainable compliance, and safety of the patients. This is the first trial with this triple combination of empagliflozin, linagliptin, and metformin. After this trial, FDA has approved this triple combination as a FDC to be marketed. And that trial has shown that superior HbA1c reduction with FDC versus individual components. Mean HbA1c change in patients with baseline HbA1c of more than 8.5 at 24 weeks, if you see, about 1.6% reduction with empagliflozin 10 milligram and 1.8% reduction with empagliflozin 25 milligram combination. This is the latest study published only in last Diabetes India in Bhubaneswar. So clinical study to evaluate the efficacy and safety of fixed dose combination of dapagliflozin, sitagliptin and metformin. The patients with type 2 diabetes inadequately controlled on metformin monotherapy, they were directly put on this triple drug. And if you see that the HbA1c reduction is robust, about 1.72%, fasting and prandial control is also significant. So triple FDC was found superior and with better tolerability than dual FDC of sitagliptin and metformin. This is MESIDA trial, which shows the combination of metformin, sitagliptin, and dapagliflozin versus sitagliptin and metformin. Again, similar results. You find more HbA1c reduction, more fasting prandial reduction, and more weight reduction. The clinical outcome is superiority of triple FDC versus dual FDC. This is another trial which has compared this triple FDC with a dual FDC of sitagliptin metformin and dual FDC of dapagliflozin metformin in 1:1:1 ratio, and you find significantly higher reduction of HbA1c with triple combination versus any of the dual combination, with significant more reduction of fasting glucose, prandial plasma glucose, and significantly greater reduction of body weight. So what is the near future need? There is a near future need of a combinatorial approach in type 2 diabetes management. If the initial HbA1c is more than 7.5, you can start with 2 drugs, and if initial HbA1c is more than 9%, you can directly choose triple FDC. So what are the important things you remember while choosing FDC? About heart benefit, you see this triple combination of sitagliptin, dapagliflozin, and metformin. Sitagliptin did not appear to increase the MACE events, hospitalization for heart failure, or other events. The metformin improved the outcome of heart failure with a reduced ejection fraction, and dapagliflozin reduced the risk of heart failure in patients with or without diabetes. The renal, again you see parameter, all the 3 molecules are showing benefit. In metabolic overweight patients, also there are similar benefits.
A request from organizers. From
so we are finished. We are finished. This is the last slide. So what was the old method? Old method was focusing on glycemia-based diabetes care. The new thing is you take care of glycemia along with a complete metabolic care in terms of body weight, NAFLD treatment, heart risk management, and kidney risk management. Thank you all for the patient hearing.
Thank you, Professor Goenka, for excellent coverage. One question is allowed. Anybody? One question you can ask. No. If there is no question, we'll go to the second topic. We invite Dr. Alok Kanungo, Challenges in Diagnosis and Diabetes in Young. Dr. Alok Kanungo, please.
With reverence to Lord Jagannath, to my teacher, Professor V.V. Tripathi, Dr. Panda, Dr. Kara, the chairpersons, Professor Jayant Panda, and Dr. Santosh Kumar Swai, and the whole team of RSSDI. I want to talk something which we are regularly facing in our day-to-day clinical practice. Diabetes in young, previously, whenever a child or a young person was coming to us, our diagnosis was type 1 diabetes. We never thought of any other diagnosis. But the change is, there is a change. This trend has started changing slowly. Type 2 diabetes mellitus, earlier considered a disorder of middle age or elderly, is increasingly being reported among young adults and now also in adolescence and childhood, probably due to the burgeoning epidemic of childhood obesity. So as per the standard classification, type 1 we know due to autoimmune beta cell destruction or latent autoimmune diabetes or of the adulthood. Type 2 is due to progressive loss of beta cells and insulin resistance.
monogenic diabetes syndrome such as neonatal diabetes and maturity onset diabetes of the young, diseases of the exocrine pancreas such as cystic fibrosis and pancreatitis, drug or chemical induced diabetes such as with glucocorticoid use, which was amplified during the COVID when huge amount of glucocorticoids were used and new diabetes, COVID-induced diabetes started coming up. And drug or chemical induced for treatment of HIV and AIDS, we find new diabetes. Gestational diabetes is known to all of us. So when we come to diabetes in young, we find type 1 diabetes, type 2 diabetes in the young, maturity onset diabetes of the young or MODI, LADA, latent autoimmune diabetes in the adult, malnutrition modulated diabetes mellitus or MMDM, which Professor Tripathi started long back in 1962, but that is now fading because of lack of malnutrition. Maternally inherited diabetes and deafness and other genetic syndromes like another 20 types of diabetes seen in the childhood, and FCPD, which is not per se diabetes. Diabetes in young adults, we say 15 to 30 years, is of different natures, and they come at different age groups and different types. And like from birth, from 10th month onwards, I have seen type 1 diabetes, and type 2, my earliest child is 9 years, which is type 2, and all other things come sequentially. So there was a data of diabetes in young registry, which says type 1 is almost 43.5%, early onset type 2 is 31%, MODI is 13.5%. Of course, in ODISHA and other places, we don't come across MODI because of lack of investigation. MMDM, GDM, FCPD 2.6% and other genetic syndromes are seen. Why there is a need for correct diagnosis and early diagnosis? Type 1 diabetes mellitus is one of the most frequent endocrine disease in children and adolescents. Diagnosis in children is becoming increasingly challenging due to high prevalence of obesity and shifting demographic composition. Correct clinical management starts with timely and accurate classification of diabetes as it guides therapy. I will show 4 cases which will clear this version of mine. Early diagnosis of the children with newly diagnosed type 1 diabetes is very important, as there is possibility of that diabetic ketoacidosis may develop, which is a life-threatening emergency. Why the diagnosis is delayed? First thing is mother is not educated. First thing, not the doctor. And health service facilities in the locality. Patient's age of presentation, 20 years. Very difficult to say it is type 1 or type 2. It is not 7 years or 5 years. Omission of main diabetic symptoms, polydipsia, polyuria, polyphagia is not understood. Only other things like perianal oral candidiasis is given the first priority, and urinary tract infection is thought of frequent urination. Wrong interpretation of main diabetic symptoms like polyuria as a sign of urinary tract, polydipsia as a habitual polydipsia, anorexia with following weight loss as loss of appetite caused by helminthiasis and some other reasons. So the abdominal pain, emesis, gasping are the signs of diabetic ketoacidosis, which is very much neglected in periphery medical setups. One of my child, 9 years old, type 1 diabetes in Dhenkanal, died because in the night he has vomiting, pain abdomen, went to the nearby PSC and was given heavy glucose load and he died. in the morning without thinking that this can be a case of diabetic ketoacidosis. Even the parents are uneducated, they could not say that the child is diabetic. So, we are in a triple road. The elevated BMI, insulin deficiency is not a good discriminator of type 1 diabetes in the immediate period, because for some time there is a high insulin secretion. Pediatric type 2 diabetes patients can quickly progress to a point of requiring insulin for glucose control. Type 2, but requires insulin for a period of some time, and we are confused that is it type 1. So, Indian diabetics are different. This is, we know it, family history and all those things. This mostly fits into type 2 diabetes. But this is a Indian scenario. So, once we come to type 1 diabetes, it is an autoimmune disease. Classical type 1 diabetes is young as onset, mostly children. Presence of one or more autoantibodies, GAD is primary. In Indian diabetics, IA2 is also primary, and other gene transporter and other things, insulin autoantibody are secondary. Absolute insulin requirement for glycemic control, decreased C-peptide levels, HbA1c is low, because type 1 diabetes never comes for prolonged period, leading to 12, 10 HbA1c. If you find HbA1c is high, think twice. Is it type 1 or not? Autoreactive T cells are the cause, and NK cell has some definite role in type 1 diabetes. If you look at what ages type 1 diabetes occurs, you can see it from 0 to 4. It starts mostly 20-25% children, and then it increases gradually. Sorry. And it continues. Just a simple picture of a normal pancreas and a insulitis you can see. You can see this is just pathogenesis of type 1 diabetes, which you don't see in type 2. It is insulinitis is the primary thing through autoimmune process. The thing that we are taught in our graduation time, that type 1 diabetes heralds. It comes with a blow, and in 24 hours the child is sick and the disease occurs. It is not that. It takes also some time. There are phases, pre-stage 1, stage 1, stage 2 and stage 3. If you look at autoimmunity, it is always present, beta cell loss is present, but symptoms are absent in stage 1 and stage 2 and present in stage 3. So, type 1 diabetes is always not abrupt. It takes time, and the antibodies that we study are islet cell, insulin autoantibody, GADA, IA2A, IA2BA and gene transporter. We are regularly doing GAD and IA2 in our setup. So, this is the first case. I will go to this space. Master Soumyajit Nayak, this happened 5 days back, was playing in DAV school CDA, DAV school Bhubaneswar, near some hospital, and his left hand started moving like this. He could not control the movement of his left hand. He was immediately taken to the some emergency, and doctor endocrinologist was fortunately available, and he diagnosed it as a hemichoria with chori type 1 diabetes. He is 13 years of age. Blood sugar was 400, and then random was 314. HbA1c was 13.2. Urine ketone was negative, and ABG was within normal limits. So, no ketoacidosis, and treatment was started on basal bolus insulin. They did the NCCT of head, impression, no significant abnormality noted in brain. MRI, impression, no significant abnormality. high HbA1c, then the child came to us after discharge from the SOM. And in view of high HbA1c, we tested his C-peptide, where fasting was 2.081 and C-peptide prandial was 7.116, cannot match type 1 diabetes. And autoimmune markers, GAD antibody was negative, 29 plus 30 plus is positive, it is 22, 38 plus is in this kit, it is positive, and IA2 was also 25. There is some autoantibody, but negative autoantibody things. So in this case, we did this test, and the insulin brought the fasting blood sugar to 120, BP to 257, HbA1c gradually decreasing. So now the child is on human actrapid 18, 16 and 14 and Lantus 16. We will wait for 2 months for glucotoxicity to go, and after that I will induce other drugs, oral drugs, because there is a safe case to try oral drugs. So this is a very interesting case, type 2 diabetes with hemichuria. My second child is Aradhya Panigrahi. It is a typical case of type 1 diabetes. C-peptide fasting was 0.5, C-peptide prandial was 1.23, her GAD was 2800, very high. It was recently detected by us, and IA2 was also high. At diagnosis, blood sugar, whatever was there, at present it is 138 and 198, and HbA1c is 7.4. So this is a typical case of type 1 diabetes, Aradhya, very brilliant child. So there is no doubt about it, and all parameters fits into that. My case 3 is another Himanshu Raut, 10-year-old, presently age of detection was 10 years, and his weight was 40 kg with an abdominal chunk of fat. And he had, when he came to me, he was on insulin, as diagnosed as type 1 diabetes, and because of the age, and I found acanthosis nigricans, and he was having bedwetting, and he never had ketoacidosis. So his C-peptide was borderline, even though not high, 1.95 and 3.07, GAD was 38.44 positive, IA2 is 243, that is positive. Antibody positive case without ketoacidosis and is being controlled at present. His present blood sugar is 79/96. So he is now on glycomet SR 500 3 times daily after careful consideration, and it is a case of possibly double diabetes, because he will definitely progress into LADA subsequently, because his C-peptide or GAD is borderline. 38 is normal and it is 38.4, is going to increase. 1 minute. And the fourth case is also a very interesting case, type 2 diabetes with recurrent pancreatitis and PCOS. A girl aged 16 years was presented to us, and we found that she has ketoacidosis because of Coca-Cola ketoacidosis. That's an interesting case. Ongul, every day 300 rupees of Coca-Cola she was taking, and now she developed ketoacidosis and again pancreatitis. Dr. Jyotirmoy Jena from SOM and me, we treated her, and diagnosis was genetic pancreatitis and with PCOS. So this is a very interesting case. The child's, if you look at the CGMS data, target range she was achieving 68%, high was only 8%, very high was 8%. And when coming, 1 minute please, and when coming, that was her graph, and then she become very normal after this. So there are maturity onset diabetes, MODI, malnutrition diabetes, there is FCPD, there is, you can know from the abdominal scan, and you can see more of beta cell defect in monogenic diabetes, and this is a very important thing. Our work And the last slide, type 1 diabetes we need insulin, fulminant diabetes insulin, LADA insulin sitagliptin, MMDM insulin oral tablets, MODI sulfonylurea or insulin, neonatal diabetes sulfonylurea, mitochondrial diabetes sulfonylurea, and type 2 diabetes in the young oral tablets. Thank you. Thank you,
Thank you,
gentlemen.
Thank you,
And,
Dr. Kanungo, for excellent case presentation, which will open the eye of many of us. So we will request our audience, please interact personally with the Dr. Kanungo. Since we do not have time, we cannot ask questions.
Thank you.
Thank you, Doctor. We'll have the third speaker right now. The topic is impact of postprandial hyperglycemia and cardiovascular system and scope for prevention. Our honorable speaker is invited, Dr. Bal Murugan from Coimbatore.
Good morning, everyone again. And at the outset, I would like to thank Professor Jayant Panta sir and the organizing committee of the RSSDI ODISHA chapter for this opportunity. I have come from Coimbatore, Tamil Nadu. Greetings from Kovai Diabetes Specialty Center and people of Tamil Nadu to you. And I'll be talking on the postprandial glycemic management in prevention of diabetic complications, why postprandial glucose control is important. And this data you would have already seen. We are expecting 592 million diabetics in 2035, and one out of 12 people with diabetes we have, as well as 1 in 2 people with diabetes do not know they have it. And there was a long debate last 20 years back whether the strict control of diabetes really helps you. People ask us. Sometimes people ask us, when they have an MI and come to with the smoking, people tell us, when you stop smoking, do we get really any benefit? Do we have any data? Something like this long debate, the little higher blood sugar, can we just leave it like that? So strict control of diabetes, was it really proved to be useful, was answered by studies like DCCT trial in type 1 diabetes control and complications. Then later, we have a UKPDS trial and follow-up of UKPDS follow-up data, which suggested that initial control, at least the first 5 years of diabetes, we call as the golden period of diabetes. When you control the diabetes at the 5 years, when in between period also the diabetes was not controlled, these people have at the benefit of reduction in the micro and macrovascular complication. This is what we have learned from the UKPDS follow-up data and what we call as the glycemic memory or legacy effect. This is the UKPDS data which as initial control helped us. And why this type 2 diabetes is important, all the colleagues here might know. Already you'll be knowing 4-fold more likely to have an MI, 8-fold more likely to die from first MI, leading cause of blindness in the age of 20 to 74, 1/3 of all cases of legal blindness, most common cause of ESRD, and 1/3 of all dialysis patients, and second most cause of the amputations. So effective management is important. So what is the post-meal hyperglycemia? So which is very important, which starts, sometimes we ask a question, the fasting blood sugar has come, the postprandial is rising first. Sometimes the egg and chicken story which has come first. So the development of type 2 diabetes is characterized by progressive decline in insulin action and relentless deterioration of the beta cell function and hence insulin secretion. So prior to we clinically and biochemically diagnose diabetes, these metabolic abnormalities are the first evident as one is the elevation of post-meal plasma glucose. My chief used to tell us when we are students in diabetes, when you want to check only one blood sugar for a patient for a diagnosis in a country like India, the postprandial blood sugar is the one you have to check, not the fasting sugar. So the post-meal glucose is the first one due to the loss of first phase of insulin secretion. Second, there is a decreased insulin sensitivity in peripheral tissues, and consequent, there is decreased suppression of the hepatic glucose output after meals due to insulin deficiency. So whenever there is insulin deficiency, the glucagon is an elder brother like. It takes an upper hand. So whenever, as long as the insulin is working, insulin is secreted sufficiently, the glucagon doesn't do much. But whenever there is insulin deficiency, the glucagon takes an upper hand, especially in the postprandial surge. It causes increased hepatic glucose output and postprandial hyperglycemia. This is also the pathophysiology of type 2 diabetes, postprandial hyperglycemia followed by the fasting hyperglycemia. And even the stage of IGT, you can find the postprandial blood sugar goes up. And when need to control the blood sugar, when we see when the A1C is 10, 11 at the time, mostly the fasting hyperglycemia contributes to that. But when you are controlling the diabetes more closer and more tighter, especially close to 7 to 8, you find the postprandial control or postprandial contribution is very, very important for diabetes control. And see how the postprandial glucose elevation happens? Because of the lack of appropriate suppression of the endogenous glucose release by both gluconeogenesis and glycogenolysis, and this decreased tissue glucose clearance, decreased glucose oxidation, as well as increased non-oxidative glycolysis and increased glycogen cycling. And this slide, I think all our colleagues have seen number of times. See, when you go to the fasting and postprandial stage, what all of us are spending, almost you can say, hardly we spend 6 hours in the fasting state, or not eating. We can't say as a fasting. Probably when you find many of our colleagues also, we find in the middle of the night also they are not sleeping at 12 noon. And if you open the WhatsApp and see, most of our colleagues are online. So morning 6 we get up to go for a work. So hardly the diabetic patients also, they spend less than 6 hours in the non-eating or fasting stage, most of the time the postprandial stage. Even the A1C of less than 6.5, you can see the data suggests that the post-glycemia or the dysglycemia, post-load dysglycemia predominates. So what is it? Why should we treat that? What are the data available? The postprandial glycemia and CVD, this is called Paris prospective study, 10-year follow-up. You can find there is a cardiovascular mortality is increased up to 2-fold. Again, this is PPG and CVD, Honolulu heart study, which is also said that PPG is a powerful predictor of increases of coronary heart disease. And what are the long-term problems with the postprandial glucose? Not only at the cardiovascular level, here look at the time of onset of proteinuria. When you are persistently, your blood sugar is less than 198, it takes 23 years for the onset of proteinuria. If it's 108 into 228, it's 19 years, and if it is more than 201 plus, it's 14 years. When you look at the patient with any microalbuminuria or proteinuria, we do not think that it's only a kidney disease. Whenever it's a microalbuminuria, it is a sign of endothelial dysfunction happening everywhere. So whenever I see a diabetic foot patient also, I tell them, diabetic foot is not plain foot alone is involved. You have a high risk of cardiovascular issues. So the endothelial dysfunction is very, very important. And this is again the data, cardiovascular data with the post-glucose. And so what do you achieve by reducing the postprandial hyperglycemia? We can avoid the risk of progression of the diabetes if you are able to catch hold of the patient in a pre-diabetic state. Today, lot of hype is being in the social media, and some people are talking about reversal of diabetes, which is a myth. Many of your colleagues will agree. It is not a reversal, it is a remission. It's only a temporary period. People are putting lot of apps. They don't go to the diabetes doctors or endocrinologists. People go to various groups of people who created app, collecting 50,000 to 1 lakh money and thinking that they are trying to reverse the diabetes, which is definitely not true. We can get only a remission, which is possible in a pre-diabetes if you are able to reduce the weight and modify the diet, and you can reduce the cardiovascular events and risk of development of new cases of hypertension also by controlling the post-meal glucose. And again, the relative risk of death increase with 2-hour blood glucose in spite of the fasting plasma glucose. And so these are the reasons why should we treat that. There is increased risk of CAD, microvascular complications, increased carotid intimal medial thickness, increased oxidative stress, and the 2 points which we learned very, very important is, the increased risk of the postprandial hyperglycemia has been linked to the increased risk of cancer. Again, the impaired cognitive function in elderly people can also be because of the postprandial hyperglycemia. How do we manage it? Very, very important. The diet with low glycemic load are beneficial in controlling the post-meal glucose levels, and several pharmacological agents preferentially lower the post-meal glucose. Diet is very, very important, and the lifestyle modification, you must understand, it's very, very, very tough to follow. even in the well-advanced centers where diabetes education is part of everyday program, where the diabetes educators are there, dietitians are there, only less than 50% of the people are compliant with the diet. If you think about people do not have an access to a dietitian, do not have an access to a diabetes educator. And we have seen patients coming and asking us after 20 years of treatment with me. Last week one patient came and he has been treated by me for last 20 years. Doctor, what is the diet for diabetes? So really, we have been educating them. So continuous education is very, very important. This is the list of the literature, the Honolulu Heart Program, Chicago Heart Study, as well as Decode Study, as well as Coutinho et al. Study, and the Whitehall Study, and Paris Prospective Study, and Helsinki Policeman Study. All have said that the post-meal hyperglycemia is linked with a cardiovascular complication. So we try to keep the blood sugar less than 140 unless there are any contraindication. What is important is, most of the time we practice in the corporate setup and hospital, patient comes in the morning, the fasting and post-breakfast, and we find the blood sugars might be normal, the A1C is very high. Sometimes we keep wondering, the fasting is 100, postprandial 200, we say A1C is 9.5, we might be wondering. So the post-lunch and the post-dinner, all the times we are not measuring. So encourage patients, educate patients to monitor the self-monitoring of blood glucose, and they will definitely understand. Now we have simple method like ambulatory blood glucose, the Freestyle Libre and Libre Pro available, so we can monitor the blood sugar all the time. And you can see here, whenever the fasting blood sugar is high, correspondingly the postprandial blood sugar also increases. There's need for controlling fasting glucose also. So if we keep the bedtime blood sugar is high in the night, again the fasting is going to be high. So it's going as a chain reaction. We have to break the chain at some point to achieve the targets. So non-pharmacological intervention, mainly the post-meal, I will tell you, most of the time it's diet related, and if you are able to control your diet, and especially the glycemic control improves, even in the patient with the IGT, and the lifestyle modification is the key. In spite of the lower compliance, we need to keep on telling the patient the lifestyle modification is an integral and primary part of diabetes management. There are weight reducing diets and exercise can normalize glucose intolerance in individuals with IGT and reduce the risk of developing type 2 diabetes. This is what we call as the remission of diabetes. And whatever weight reduction you are able to achieve, really beneficial. Even 5 to 10% of the body weight reduction over the period of 6 to 1 year is really beneficial. So the reduction in consumption of meals containing high glycemic index, very, very important, so that they lower the post-glucose value. What are the drugs available? These are all the drugs which are familiar to all our colleagues. Alpha-glucosidase inhibitor, short-acting sulfonylureas, how the acarbose and oglibose act. See, basically, even though the A1C reduction is around 0.8%, they do not cause hyperinsulinemia. Again, they improve the GLP-1 profile also. And again, this is how, the delaying the digestion and absorption of carbohydrate, and the drugs like acarbose blend the postprandial glycemic spikes by competitive reversible inhibition of the intestinal alpha-glucosidase enzyme. And you can about the short-acting sulfonylurea glipizide, I think we are almost, with the advent of SGLT, DPP4, these drugs are very, very, very less used. And we have repaglinate, which is also, even though mild, doesn't cause, it's not a very potent sulfonylurea, glenadine, it can help in controlling the postprandial. We have what is latest, insulin analogs. These are all, we call as some sort of designer dresses, designer blouses. These are all designer insulins which are made to work shorter for a period of time. Some insulin works on a longer time. These are all analogs. So insulin analogs provide more closer physiological insulin delivery, greater convenience due to flexible timing of injection, provide almost identical long-term glycemic control, more weight. One of the advantages, the patient with a prandial injection, you can just take before food. If you forget, in between food also you can take that analog, and even after taking, you can also take. Suppose a person takes less quantity of food, the chance that you can, insulin dose can also be reduced, and this act, the data available, these analogs are very superior. Of course, they are expensive, so whoever can afford, please give it. These are rapid acting analogs. And talk about the incretins, apart from the insulin deficiency, insulin resistance, we have the strategy to turn on the GLP-1 receptors. The native GLP-1 chronic infusion, we have GLP analogs like exenatide, liraglutide, we have dulaglutide, and semaglutide now available. And soon the semaglutide injection is going to be available in India. and we have all the DP4 inhibitors in the list. And these incretin mimetics, very, very important is they have to be given as an injection, and they increase the GLP-1 levels to the supraphysiological levels, almost 6 to 10 fold, which is responsible for the side effect. And they like nausea and vomiting, but they have a longer half-life. And main advantage is definitely superior A1C reduction, only next to the insulins. When you look at the efficiency of all anti-diabetic drugs, insulin is number one. The GLP-1 comes next, second one. So body weight reduction, whenever you find a patient with a higher BMI, obesity, these drugs really work well, reducing the weight as well as reducing the A1C. And we have data in terms of cardiovascular data also in this. We have data from the LEADER trial and most of the trials from the semaglutide. The PIONEER trials also seems to be beneficial. And this is about the GLP-1 effects. All of our colleagues will know about it. So the GLP-1, it's very, very important. The unique mechanism being it stops releasing or stimulating the beta cells once the blood sugar reaches normal. This is what we call as the glucose-mediated or glucose-dependent insulin secretion. All the gliptins, you are all familiar. When you look at the various drugs in A1C in the postprandial reduction, you can just see the A1C reduction. I said the GLP-1 scores first, followed by the other drugs, and we can choose the drug according to the patient's convenience and the economy also. If you use the prandial insulin, going to be effective, but little expensive. Similarly, if you use a GLP-1, it's quite good, and now also we are getting these GLP-1 injections at a lower cost level. Also, few pharmas have launched at a lower cost the liraglutide, so you can try that in people who want to reduce the cost also. But by and large, these drugs can be used. So first key is the lifestyle modification. Dear colleagues and friends, the lifestyle modification is very, very key factor in reducing or controlling the postprandial blood glucose levels. Unless you control the diet, and you cannot control the postprandial blood sugar levels. Thank you very much for the opportunity.
Thank you, Dr. Murugan, for finishing the bang in time. And I think it gives the privilege to have one questions. Anybody from the audience for a question for Dr. Murugan? Bala Murugan, sorry, it is Bala Murugan. With this, we come to the end of this session. We thank the organizers for giving us the opportunity to chair this session.
Thank you, sir. Thank you.
And we could.
Actually, we had a very interesting session, the inaugural session of the day, where we learned the SGLT2 inhibitors and the diabetes in the young, the challenges Dr. Kanungo covered very novelly. And we had our invited speaker, Dr. Balmurugan, who took you through the postprandial hypoglycemia and the intervention. 3 important topics covered. Give a big hand to the speakers and the chairpersons, and immediately we'll move forward. I request to invite the chairpersons of the next session, and our chairpersons and speakers are requested to come to the memento area for felicitation, and request Sandeep to accompany our speakers and chairpersons to the memento area for felicitation. Thank you, sir. Over to
Without further delay, we would like to proceed for the 6th scientific session of the day. The topics are diabetic autonomic neuropathy detection and intervention, management of hyperglycemia in ICU or HDU, and diabetic dyslipidemia. The speakers for the 6th scientific session are Dr. Nivedita Misra from Jamshedpur, Dr. Shambhu Datta from Visakhapatnam, Dr. Akash K.N. Singh from Vadodara. Now, I would like to extend my heartfelt welcome to all the chairpersons of this session. Dr. Santosh Kumar Swai, Associate Professor, Department of Medicine, SC Medical College, Puri. Dr. Satyapriya Misra, Senior Consultant Physician from Puri. Next, I would like to invite our final chairman, Dr. Banambar Senapati, Honorary Secretary, IMA Puri Branch. Thank you, sir.
So our first talk is about diabetic autonomic neuropathy detection and intervention. So I call upon Dr. Nivedita Misra Madam to the dais. She is the head consultant, Department of Medicine, Tata Main Hospital, Jamshedpur. She has been published 7 papers in national and international journals, and
this is not the topic.
diabetic autonomic neuropathy.
Autonomic neuropathy.
Just check the PPT.
Autonomic neuropathy.
कर दीजिए ऑन कर दियो
Okay, madam. Over to you, madam.
Good morning, everyone. Sorry for that change of the topic. The wrong one was loaded. Anyway, my respect to all the senior physicians, all the professors of my state. I have been away in the neighboring state, Jharkhand, for so long. So thanks to Professor Jayant Panda to call me back and into the circle of my own state physicians. Very glad to be here. So I was given this topic of diabetic autonomic neuropathy detection and prevention. So the incidence and prevalence of diabetes, as you know, has been increasing, and 425 million people throughout the world, 40.9 million in India, that was some time back, and raising to 70 million by 25, so likely to associate with high degree of complications. And DAN, or diabetic autonomic neuropathy, is among the least recognized and least understood complications of diabetes. It can have a significant negative impact on the survival and quality of life in people with diabetes. And the metabolic disorder of diabetes leads to diffuse and widespread damage to peripheral and autonomic nerves and small vessels. It affects the autonomic nervous system, cardiovascular, GI, genitourinary, and neurovascular systems. So it has been defined as a disorder of the autonomic nervous system in the setting of diabetes or metabolic derangements of even pre-diabetes after exclusion of other causes. In other words, after ruling out alternative causes of autonomic neuropathy, DAN is described as a malfunction or impairment of the sympathetic and parasympathetic autonomic nervous system in diabetic individuals. So autonomic nervous system has been designed to maintain homeostasis by maintaining sympathetic and parasympathetic nervous systems. The sympathetic component is fight or flight, and parasympathetic is rest and digest, all our first MBBS lessons. So this shows the broad network of the autonomic nervous system. All starts from the CNS. The preganglionic network of the sympathetic are small, whereas the preganglionic fibers of the parasympathetic are long. So the diabetic neuropathy has been classified according to diffuse mononeuropathy and radiculopathies. And in diffuse neuropathy, apart from the commonest distal symmetric polyneuropathy, the autonomic neuropathies come in this category. So these are broadly divided into cardiovascular, gastrointestinal, urogenital system, and pseudomotor dysfunction. We will go about the various presentations later on. So autonomic neuropathy is often missed unless it is overtly symptomatic. In all diabetic patients, we should elicit the history of dysautonomia and confirm it by physical examination, since it is associated with increased mortality. It can manifest as generalized autonomic neuropathy. Even in pre-diabetic state can cause autonomic neuropathy. And also treatment-induced neuropathy is a specific entity. It may also occur during or after hypoglycemia, causing hypoglycemia unawareness. And it can be cardiac autonomic neuropathy, pseudomotor neuropathy, gastrointestinal autonomic neuropathy, and urogenital autonomic neuropathy. So this broadly summarizes the various symptoms. In cardiovascular, it can have postural hypotension, postprandial hypotension, fixed tachycardia, and food complications can also give rise to, due to cardiovascular neuropathy. Sudden cardiac death is also a very dangerous complication of that. Then GI autonomic neuropathy can give rise to motility disorders of the esophagus, gastroparesis, constipation, diarrhea, then genitourinary causing bladder dysfunction and sexual dysfunction, pseudomotor neuropathy causing anhidrosis, gustatory sweating, causing shiny skin, loss of nails, etc., abnormal pupillary responses, and neuroendocrine responses to hypoglycemia can lead to hypoglycemia unawareness. So the prevalence of diabetic polyneuropathy, according to the duration, more than 10 years, 36% have been found to have polyneuropathy in both the type 1 and type 2 diabetes. So the prevalence of diabetic autonomic neuropathy in type 1 has varied from 1% to 90% in different studies because of the discrepancies in the diagnostic criteria. That is why such a large range. And the consensus panel on diabetic neuropathy had to do exhaustive study to find out the prevalence of cardiac autonomic neuropathy, which also varies from different studies from 20% to 65%. So the risk factors which make it predisposition for autonomic neuropathy varies according to the duration, the age, other microvascular complications, the state of glycemic control, and presence of other comorbidities. So this also has defined the risk factors of diabetes, risk factors leading rise to neuropathy and also to painful diabetic neuropathy. Coming to the pathogenesis, the DAN and CAN, both pathogenesis are similar to the peripheral neuropathy, increased in the advanced glycation end products, nutrition shortages, immune mediated, oxidative stress, hormonal factors, growth factor inadequacy, neurovascular insufficiency, and metabolic insult to neurons. Hyperglycemia and dyslipidemia directly affect the nerve axons and the dorsal root ganglia and Schwann cells, and multiple mechanisms have been invoked: the polyol pathway activation, oxidative stress, protein kinase C activation, and AGE, that is the advanced glycation end product formation. However, recently the focus has shifted to dyslipidemia and triacyl glycerols, giving rise to NEFA, that is non-esterified fatty acids. They are catabolized by beta oxidation. It all comes down to oxidative products and toxic acyl carnitine. And the LDLs can also induce reactive oxygen species, which can act through AGE, LDLs, and toll-like receptor 4, which exacerbates the nerve injury. And also altered sphingolipid metabolism has been incriminated. So this gives a broad picture of the different pathophysiologic mechanisms causing diabetic neuropathy. This again summarizes This again summarizes the symptoms of the various autonomic neuropathies. In cardiovascular, resting tachycardia, abnormal blood pressure, that is in ABPM we saw the non-dipping and the reverse dipping. And in also can give rise to orthostatic hypotension, giving rise to all these symptoms, and then orthostatic tachycardia or bradycardia and chronotropic incompetence. That is that we will see in the autonomic testing. And GI neuropathy giving rise to gastroparesis, esophageal dysfunction, diabetic diarrhea, and also constipation. And urogenital giving rise to bladder dysfunction, male sexual dysfunction, also female sexual dysfunction, and pseudomotor neuropathy giving rise to dry skin, anhidrosis, etc. So the cardiovascular is the most underappreciated consequence. Though it is in early phase, it seems to be quiet, but it is a robust predictor of mortality and poses a significant challenge due to a significant risk of silent myocardial ischemia, sudden death, and cardiac arrhythmias. They can have 5-fold greater risk of mortality, so that is not small. So 3 pathophysical disorders are linked with CAN. One is orthostatic hypotension with supine hypertension, reflex cardiovascular syndromes, as we will see later on, and postural orthostatic tachycardia syndrome, otherwise POTS. So at great risk are those with increasing age, uncontrolled diabetes, other risk factors, and smoking. The few microRNAs have been incriminated, and also low level of B12 and vitamin D have been associated with CAN. So here are few cardiovascular autonomic reflex testing, otherwise known as CARTs. The Valsalva technique, where after 15 seconds of sitting silently, the person will blow into a mouthpiece at 40 millimeter mercury. During the procedure, it will normally at the 15th beat, it will have a rebound, normally it will increase followed by a rebound bradycardia. So the ratio to the longest RR period after the move is calculated. This is average of 3 Valsalva motions are calculated. There another is heart rate response to deep breathing. The person will sit quietly and breathe evenly at a rate of 6 breaths per minute. The maximum and the lowest heart rates during each breathing cycle are measured, and the difference is averaged. And there is another standing up. Here is the 15th and 30th ratio. After standing up, normally there is an increase in heart rate around the 15th beat, and then it comes down relative bradycardia around the 30th beat. So the 30:15 ratio will give you the value. Then there is a continuous hand grip used by the hand grip dynamometer, as we were seeing yesterday, at 30% of maximal voluntary contraction at a maximum of 5 minutes. The difference in the diastolic blood pressure immediately before the hand grip release and just before commencing the test is used to determine the responsiveness. And also standing up will cause a rise of blood pressure in normal persons, but in the diabetic autonomic neuropathy, the difference in the systolic BP will not happen as expected. So this will be used to calculate. So there are other advanced tests which can be used by MIBG scan. There is small nerve fiber function can be used as a surrogate marker. Skin biopsy can also be used for intraepidermal nerve fiber measuring nerve fiber density. Then another corneal confocal microscopy CCM, it can diagnose CAN with a sensitivity of 86 to 100%. And optical coherence tomography can also measure the retinal nerve fiber, which is useful in detecting early diabetic peripheral neuropathy. These are the various stages of CAN. When there is first heart rate variability test is positive, it is possible early CAN. When the second and third test are positive, it is definite. Then orthostatic hypotension means it is already severe and advanced stage, and after that patient becomes symptomatic. Coming to other autonomic testing in GI and urologic, gastric emptying scintigraphy, isotope based breath test, anorectal manometry, and urologic testing like post-void residual urine in the ultrasound, urodynamic studies, nocturnal penile tumescence, and penile and brachial blood pressure and penile brachial pressure index can be used for autonomic function testing. Then coming to the treatment of CAN, symptomatic patients, we have to stop other drugs which can cause orthostatic hypotension, and pharmacological therapy consists of fludrocortisone 0.1 to 0.4 milligram, midodrine in dose of 2.5 to 5 milligram twice a day can be used. Droxidopa is actually used in other causes of neurogenic OH, but in CAN-associated OH it is not well established. Octreotide 50 microgram 3 times a day subcutaneously can also help in postprandial hypotension. Fludrocortisone and midodrine should be used carefully because of the risk of supine hypertension. For GI autonomic neuropathy, treatment is usually small frequent meals, preferably semi-liquid along with prokinetic agents, and a low fiber, low fat diet, and necessary to avoid carbonated drinks, chewing gum. Patient with diabetic gastroparesis should discontinue the use of GLP-1 analogs and DPP-4 inhibitors, as they also act through the similar pathway. And those who have been suspected with small intestinal bacterial overgrowth, they should be given antibiotic therapy. And for diabetic diarrhea, we have to avoid metformin, using loperamide as and when required basis, and GERD, PPI, and other prokinetic agents, as we all do. And for genitourinary, we have to discontinue other medications which inhibit the detrusor activity, like anticholinergics and tricyclic antidepressants, and a voluntary urination schedule that is a time guided, and PD5 inhibitors such as sildenafil are the therapies for erectile dysfunction. So treatment-induced neuropathy is a definite entity where it has been found to occur in patients where rapid glycemic control is achieved in the presence of high pre-treatment HbA1c. In both type 1 and type 2 DM with insulin or oral hypoglycemic agent, we can find such an entity. And dysautonomia and neuralgia are the cardinal features. Dysautonomia improves, especially in type 1 diabetes. Nephropathy and retinopathy are also known to increase concomitantly. So coming to the therapy, DAN, there is no effective therapy to stop or reverse DAN, but the effect of intensive insulin therapy helps in slowing the progression, mostly in type 1 DM, but in type 2 DM, the other drugs like sulfonylureas and all our routinely used drugs have shown beneficial effects. Metformin but seems to worsen the neuropathic damage because of its deficiency of B12 deficiency which it induces. The other antioxidant therapy like alpha lipoic acid, vitamin E, by acting on the heart rate variability is controversial. Aldose reductase inhibitors have been are being available now commercially, but results are not very encouraging. C-peptide has shown sometimes a beneficial effect in type 1 patients, and antihypertensive drugs like ACE inhibitors, ARBs, and cardioselective beta blockers, they also can help in the heart rate variability problem. And orthostatic hypotension therapy has been investigated with lifestyle, behavioral measures, and physical counter maneuvers, and midodrine has been approved by the FDA. And other drugs like alpha-2 agonist, mineralocorticoids, somatostatin, like I told earlier, they also have been found to ameliorate the symptoms, but limited effectiveness. And other newer therapies are being developed, and stem cells and gene therapy are obviously being investigated. But more important is the prevention, because therapy is not very effective. But in prevention, intensive glycemic control is most definite in type 1, but in type 2, the DCCT has demonstrated that intensive glycemic treatment can reduce the diabetic complications and can by 53%. But the EDIC study has demonstrated that there are persistent beneficial effect of early strict glycemic control on DAN and also CAN. So this is the DCCT study. It showed that keeping blood glucose levels as close to normal slows the onset and progression by 60%. And in type 2 DM, intensive glycemic control seemed to be less effective than type 1 DM. There is a VA cooperative study where there was no difference was found in the prevalence of autonomic neuropathy. And large studies, 3 large studies, VADT, ACCORD, and ADVANCE, they have reported that it does not, and intensive glycemic control does not reduce all-cause mortality. So this is the Barry 2D study where the patients were followed up for 4 years during the study, and a glycemic control therapy with insulin sensitizing agents reduces the incidence of polyneuropathy rather than compared with insulin providing therapy. And the best results seem to be derived by multifactorial strategy treatment and lifestyle modification. Steno 2 study also, finishing sir, Steno 2 study also added proof to that, and the DPP lifestyle modification where losing weight, physical activity, they are all helpful, and depending on weight loss also it helps a lot. This is glucose control is critical, but in the end you can see that in type 2 the evidence is either plus or minus. So the take home message is DAN, though it is common, it remains underdiagnosed, thus contributing to the morbidity of diabetes. The ADA therefore recommends screening for DAN at the time of diagnosis of type 2 DM, but as you know already 5 years might have passed, and 5 years after the diagnosis of type 1 DM. The screening should include a history of eliciting symptoms like orthostatic symptoms, fainting, diarrhea, GERD, erectile dysfunction, etc. And the test of heart rate variability may be indicated. If initial screening is negative, a history and physical examination for signs of autonomic dysfunction should be repeated every year. And the identification of subclinical DAN is useful for risk stratification and for individualization of glycemic, lipid and blood targets. Thank you.
Thank you, madam, for your detailed elaboration. As we know, the diabetic autonomic neuropathy is underrated and underestimated, but most dreadful complications occur due to that only. Thank you, madam, for your presentation. Now we can take up 2 questions from the. Okay, we are running late. We can go to the next session.
Thank you.
Thank you. Jai Jagannath, good morning and welcome to Puri, to all of you to Puri, the place of Lord Jagannath. In diabetes, in hospitalized patients, many times we see dysglycemia, either hypoglycemia or hypoglycemia. And all hyperglycemic patients presenting to hospital are not diabetics. In many situations also, non-diabetes patients are also present with hyperglycemia to hospital. And in ICU and HDU patients also present with hyperglycemia. So I will invite Surgeon Captain Colonel Dr. Shambhu Datta from Vizag to discuss about management of hyperglycemia in ICU and HDU patients. Over to you, sir.
Thank you, all chairpersons, sir. And my special thanks to Professor Jayant Panda, Professor Santosh for inviting me here from Visakhapatnam, and all the respected, my teachers are, many teachers are there, my colleagues and friends are there, and I am extremely happy today morning when I got down from the train at 5:55 because there is no direct flight between Vizag and Bhubaneswar off late. So with a military precision, one man caught me without any signs and shows. Then I could realize the precision, the kind of military precision they are working. So I must congratulate them for the extremely high degree of dedication for this conference, and happy to be here. Thank you. So basically blood glucose management in ICU and HDU, the challenges, as my previous madam spoke, that tight glycemic control can actually, the one thing which can help in autonomic neuropathy control. However, in ICU, the scenario is little different. So hyperglycemia in hospital, actually, whenever the blood glucose is 140 random in both patients, either diabetic or undiagnosed diabetic, we call it hyperglycemia in hospital. Stress hyperglycemia, elevation of blood glucose level, who are previously undiagnosed diabetes, but HbA1c is more than 6.5, less than 6.5, they are all stress hyperglycemia. Okay, now we'll come to stress hyperglycemia. It is actually more risky than a type 2 diabetes who comes to ICU. Most of the observational studies, they have shown that almost 50% critical illness in ICU or HDU, they have hyperglycemia. Out of that, 22% they had diabetes, 5.5 unrecognized, and 22.7 they had they have post-cardiac surgery. When they come to ICU, they have hyperglycemia, whether they are diabetic or not. So why blood glucose control is very important in ICU? Because most of the studies, they have shown that hyperglycemia adversely impacts mortality, morbidity, rate of infections, and length of ICU stay, that is LOS. And we must remember that hyperglycemia commonly ensues even in patients who do not have pre-existing diabetes, as I told. And the rationale behind use of insulin in critically ill, that either severely injured or infectious patients, in them carbohydrate metabolism is altered, and that causes severe insulin resistance in critical care. And there are 3 types of hyperglycemic patients in ICU. Either one is a non-diabetic, one is diabetic, but we could not know. First time he landed up in ICU and he is a diabetic actually. Others are stress hyperglycemia, which is a major chunk. So these are actually the causes. You can see the arrow mark on the left side. These are the main problem. IV dextrose glucocorticoids heavily used in ICU. I mean, you know that during COVID time also used glucocorticoids, and that also created a lot of diabetics. Catecholamines are very high in these patients. Inflammatory cytokines. Then TPN we use, parenteral nutrition, enteral nutrition. All this can cause. Other than that, other tissue effects, circulatory electrolyte effects, protein catabolism, all these things can cause hyperglycemia. This is a very important slide where in Journal of Clinical Endocrinology, it shows that a new hyperglycemia mortality is more. That means stress hyperglycemia patient may die almost 5 times more than a non-diabetes, 16 versus 3%. So that is most important. And this is another hyperglycemia pneumonia outcome study. In that also we have seen the admission, ICU admission blood glucose when it was more than 200 and more than 250, the mortality was at the tune of almost 30%, 25 to 30. So that is why whenever your patient has got high blood sugar in ICU, always be more careful because mortality is very high. So this is another medical ICU, and this is also from Mayo Clinic, and they have also shown almost 3 to 4 times more when the hyperglycemia is in the range of 200 to 300. So glycemic control among the critically ill patients, topic of serious attentions. There are intensive versus moderate blood glucose control, but with the gain of wisdom, the pursuit of tight glycemic control among the critically ill patients have been seen to be counterproductive. So moderate glycemic control is the standard practice now. At present, the key attention areas with the CGM and other things, we are more into hypoglycemic episodes, glycemic variability, which is very important. Now we are using a lot of CGMs and continuously monitoring the glucose, and pre-morbid diabetic status. That means if the patient has got a stress hyperglycemia without type 2 diabetes or type 1 diabetes, he has more chances of death. So this is the NICE sugar control 2009. This actually, here intensive infusion was given to control the blood glucose between 144 to 180, and 90-day survival both was the primary endpoint. And what happened? The NICE sugar study actually put most of the research trial, it put a nail in the coffin, because it showed that normoglycemia, which was earlier there, normoglycemia in intensive care, survival using glucose algorithm was published, and this multi-center trial, NICE sugar trial, with almost 6,000 odd patients, both medical and surgical ICUs, 42 ICUs around the world, that intensive insulin therapy, which will decrease the 90 days mortality, was actually refuted. Now you see, except 2 things, either trauma cases or corticosteroid cases, most of the other cases in ICU, they show when you don't go for very intensive control, rather go for conventional control, the mortality is much better and outcome is much better. So intensive insulin therapy in ICU is, after NICE control study, sugar control study was stopped. So the summary of the NICE trial is, this is one of the largest RCTs in the history of critical care. NICE sugar trial shows increased mortality with an intensive insulin therapy or intensive glucose control strategy. And when the target levels earlier were recommended to 80 and 108, 81 to 108, when compared with 144 to 180, severe hypoglycemia was more common in the intensive group, and there was a strong association between hypoglycemia and mortality. So the more lower the glucose levels, more higher the risk of death. So NICE sugar control trial, it put a robust evidence that lowering the blood glucose level below a threshold of 144 does not offer any additional benefit. Rather, it carries very high risk for poor outcomes. So this is very well conducted multi-center trial. Okay. And tight glucose control study was refuted. And next, this is very recent study in NEGM 2023, they did a TGC fast trial summary. In that also, there was not much of difference between discharge alive from ICU between the tight glucose control, that is 80 to 110, and insulin was started when only the sugar was 215 or below. So that was the outcome, there was no difference. So this TGC fast trial, if you see, 90 days mortality, there is not much of difference, 10.1 versus 10.5. And occurrence of severe hypoglycemia was 0.7 versus 1 in tight group. So why did nice sugar show a mortality? Whereas in 2001, actually Vanderberg study, he actually proposed that tight control. But Vanderberg in 2001, only a single center study. It was a single center study, and it was in the Belgian ICUs. We know the Belgian watches are very famous for their precision. Similarly, Belgian study, but it was single center study. They had lot of parameters. They used TPN also. So probably all these things actually, and in Vanderberg, he also used early parenteral nutrition. Maybe there was a spike in glucose. Maybe that is why in the first Vanderberg 2001 trial was showing tight in sugar control was better. But later on, this is a single center study, and by this nice sugar control and these TGC studies, that was refuted, and now we are no more practicing tight sugar control. So these are all the trials on tight and glycemic and liberal glucose control. Most of the studies you see, the recent studies like the reds circled and the next the TGC fast, if you see the newer studies, they all favor liberal glucose control. Current recommendation of management of hyperglycemia, what we are recommending as per ADA, AACC or SCCM and Society of Thoracic Surgery, that keep the sugar between 140 to 180 by infusion insulin. And given the heterogeneity of the ICU population, it is evident that glycemic control and target outcome, one size may not fit all. Like when the patient is a post cardiothoracic surgery or patient is on high dose of steroid, those things may be different. And hyperglycemia is associated with worse outcome is in non-diabetic patients. This is also I told categorically that stress hyperglycemia is a very strong risk factor for death. Now AAC, ADA consensus, so this is also same. Basically we should, pre-meal blood glucose should be less than 140, random should be less than 180. Same in ICU setting also, we keep between 140 to 180, and we start insulin when the threshold is around 180. So these are already discussed previously by the speakers, that these are the types of insulin mostly used. There are short acting and there are long actings. Okay, so we give basal bolus regimen. Mixtard earlier used a lot of poor, but now mixtard is not used because of it has got a non-physiological mode. You know that it has got 2 peaks and it doesn't go as per. It probably in a OPD setup it is good. So these are the insulin infusion protocol. This was most of the institute, they have their own protocol, but most of the people they follow. Professor Dr. Kalraj, this is very famous protocol. We mostly use this protocol only. That is basically you have to 50 units of regular insulin, you dissolve in 50 ml, put in infusion pump and titrate and give. Problem is most of the time ICU, when we leave, doctors many times like small setups and poor setups, when the nurses are not very equipped, and then hypoglycemia major problem. By 4 or 5 hours, blood glucose levels come down below 120 or 130, and hypo is very common. So nowadays, of course, continuous glucose monitoring in ICU and other things, artificial intelligence are preventing all those things. So this is the blood glucose level and dose of insulin you can give, but you can titrate as per your institution and your convenience, because hypoglycemia we should avoid at any cost. So now current JAMA, I was, before coming I was just seeing the slides. So current JAMA this year they have published that even when the patient is hemodynamically stable, diabetic ketoacidosis or hyperosmolar coma, if the patient hemodynamically stable, we can also give subcutaneous insulin, which I also use since many days, but most of our colleagues also use. When setup is not very accurate, we can use subcutaneous if hemodynamically patient is stable. So we can use, that is safe also, and this has come in recent JAMA also. So risk factors for hyperglycemia, these are basically already I have discussed in one of the cartoon slides, corticosteroid, catecholamines, inflammatory mediators, and hypo, other side, when you are using insulin infusions causing tight glucose control, you can have other drugs, you have to very important, like octreotide, as ma'am also told, for diabetic autoimmune neuropathy, beta blockers, antibiotics, especially quinine and levofloxacin. Quinine very much used in ICUs. Nowadays, of course, Falsigo has come. So levo also used for pneumonia cases, so this can cause hypoglycemia. So now another problem is nowadays we are doing point of POC test, point of contact test, mostly with our this normal finger prick blood glucose. That can have problem in the ICU, because ICU, you know that because of hemodynamic instability, the capillary flow and other things, circulation are not very accurate. So it can give very high readings, okay, and overestimates in all glucose range, especially in hypoglycemia, it may not detect. Similarly, hyperglycemia also it cannot detect. So that is limited. So we should always send in between one sample venous blood glucose or arterial blood glucose to ICU, to lab, our lab, to check our ICU POC test standards, as well as to be on the safer side. So, but these are the new generation glucometers. This is GlucoX Pro and AccuCheck Guide Me. These are very good. They have largely overcome the fallacies of their predecessors, and almost in ICU, they have most of the trials in ICU have shown that 97% correlation with the lab tests when you are using GlucoX Pro and AccuCheck, and it has got very low risk of insulin dosing error, and they are mobile phone compatible. This is one of the advantage whenever the nurse or ICU physician is doing. If you are in charge of the case with your mobile, you can have the GlucoX Pro and AccuCheck this Guide Me data in your mobile. So from a distance, you can monitor better. So application of artificial intelligence in ICU now, artificial intelligence has come in a great way in most of the medical, this thing, it is, I think, the second biggest sector in any technology. Medical setup is the biggest AI application sector. Blood glucose monitoring prediction, detection of adverse glycemic event, blood glucose control strategies, even insulin bolus calculator in ICU also, and risk of patient stratification we can do with this AI. So in we know that open loop versus closed loop, this is mostly used by the endocrinologists in OPD or non-ICU settings, but now in ICU also artificial pancreas or closed loop has come. So this is basically, it has got a sensor, it has got an insulin pump, and with the AI, it decides the artificial intelligence is there. So with that, it can decide how much insulin is required. If the patient has got hypo, it will give alarm to your mobile or other devices. So this is highly developed, and some trials have been done all over world. Okay, so this is what I told. Basically, it has got a sensor, a CGM receiver, insulin pump, and algorithms. These algorithms now, everything is in AI, and they can be actually put in your mobile as the app, and you can see what is happening in the ICU, and you can decide. And with its own AI, it will also give the therapeutic dose of insulin. So these are the difference between open loop. Open loop is when there is actually human interference. Open loop when the ICU nurse or the physician gets the blood glucose level and injects, the human interference is there. In closed loop, everything is closed, so system does everything. That is the advantage of AI, but there is little bit of problem also in case error happens, but there are a lot of safety standards also. So problem with current open loop. Current open loop, as I told, manually you have to check the glucose. You enter the glucose into the software, and then you have to adjust the pump every time. Okay, so this is a trial actually with a type 1 diabetic hospitalized, fully closed loop insulin delivery system, fully automatized. So this machine was CAMP HX. It improved the glucose compared to insulin pump therapy, open therapy. So closed therapy or fully automated was doing better than the older ones. Yeah, I'll finish in 1 minute. So transition from intravenous to subcutaneous insulin therapy, there are a lot of this thing. Basically what we do, subcutaneous insulin is 80% of the insulin administered in the preceding last 24 hours. And then we divide into two parts. So this is basal bolus. We know that 50% of the last 80% of the dose you give by basal, and then bolus you give, that is short acting breakfast, lunch and dinner, and you can use a correctional insulin in between pre-meals. So there are rabbit-2 trial. This rabbit-2 trial actually published in NEJM, and this shows that basal bolus is better than subcutaneous. So this is better. Post-operative management, also we use this Miami 4/12. This is basically use the rapid-acting insulin and 1 unit insulin subcutaneously every 10 to 15 gram of carbohydrate by a Miami 4/12. Basically you divide this, basically you can remember weight divided by 4, that is suppose patient has got 60 kg, so 60 by 4, 15 unit is basal, and if you divide by 12, that's 60 kg, that is prepandial. So this is used in our ICUs also, and when you shift to HDU or WAD. So this already I have discussed. Mostly the things are blood glucose control should be 140 to 180, not very tight. Time in range, 70% is very good, but remember when the patient is elderly or having CKD, most of the or liver disease, then try to keep time in range. 50% of the time is good. Elderly person, we don't keep 70%, ideally 70. For young persons or those who are pregnancy, in those groups, we require tight control. Glycemic gap, that is 40 milligram. We should keep. Glycemic lability, another factor which is coming in ICU, that is median is less than 40. Stress hyperglycemia ratio 1.14. So these all are there in literature, and glycemic variation should be less than 36% coefficient variation. These are all calculations which are coming in the app nowadays. And recommendation diabetes care in hospital, already discussed this slide, 140 to 180 we keep. And key points: hyperglycemia associated with increased morbidity and mortality. Enhancing the amount of time in glucose levels is the target range. Now the new target range is your glucose level at any point of time should be 70% of time at least should be between 140 to 180. So that is more important. Hypoglycemia is independently associated with very increased risk of death. Optimal blood glucose control in the intensive care unit is still not known and controversial. Conclusion: blood glucose monitoring is very important in ICU, and target of 140 to 180 is the most acceptable. Okay, and non-diabetic critically ill patients prone to glycemic fluctuations, so more frequent blood sampling is required. What are the challenges in ICU? Multiple medications. Some medications can increase or decrease the blood glucose. Presence of underlying comorbidity like CKD patients or liver failure patients, they have more problems. Organ dysfunction, rapidly changing hemodynamic problem. Then capillary blood testing, which you do in ICU, it may not be very reliable. And newer glycemic indices, like we discussed, glycemic variability and time in target range, TI-TR is more important. CGM is being increasingly used in ICU, and with artificial intelligence-based devices, they are actually helping for comprehensive glucose control in most of the future ICUs. Thank you, and Jai Hind from Vizag.
Thank you. Thank you, sir, for your excellent presentation. Thank you. Any question from the floor?
Thank you, Dr. Sambodhat, for your nice presentation. I am Dr. Banshidhar Sir from Kids Hospital, Bhubaneswar. We day and every day we manage these type of cases, and he has explained it nicely. But I will just, for compliment, I will tell in 3 sentences how to manage diabetes in ICU, HDO, ward, casualty, everywhere. Whenever any patient comes with to ICU with 200, 300, 400, 500, we have managed up to 1000 mg/%. So do glucose, have syringe pump, and add insulin 40 units, 1 ml in 39 ml of normal saline, and infuse at the rate of whatever amount of sugar is there. Suppose 500, 5 ml per hour, if not ketoacidosis. Normal cases, ketoacidosis, high dose is required. 400 ml, 4 ml per hour, 300, 3 ml per hour, 200, 2 ml per hour, 1000, 10 ml per hour, 900, 9 ml per hour. Very simple. Everybody can remember. The amount of sugar in 100 ml of insulin infusion per hour. Very simple. Nobody can forget this. And then when blood sugar comes below 200, then we have to maintain between 150 to 200. So we have to give 0.5 to 1 ml per hour. So that it will be maintained between 140. Suppose you will stop at the rate of 200 mg/%, then blood glucose will again increase. So we have to keep between 150 to 200. So we have to give 0.5 to 1 ml, as Harrison tells, 0.5 to 1 ml per hour. So this is very simple thing to manage diabetes in ICU. But this is in normal cases, when patient is taking normal food. When patient is in IV therapy, patient is in rice tube feeding, in that case, same thing will give, but in IV therapy we have to add DNS. We have to give DNS also.
Sir, we are running very late. 1 hour late.
One second.
Sir.
DNS.
We will have the inauguration, sir.
One second.
Please, sir.
We have to give IV fluid with insulin and some particular. Sir, while giving this infusion, always you have to monitor sodium potassium, because potassium will fall. So we have to give oral potassium, patient can take, otherwise potassium infusion.
Thank you, sir.
Thank you.
Half a minute. Thing is that in a critical setting in ICU, Dr. Sambhudat has told very excellent presentation. But thing is that in most of the cases, in the early morning, in 3 a.m., 4 a.m., the people are going into absolute hypoglycemia. So in many institutes in the critically ill patients in the ICU, we have seen many patients are going into hypoglycemia in the late, early morning. So because that has been monitored, or the blood, the insulin infusion, they have to make, as you have told, it is 140 to 180. It should be around 160 to 180, little more in elderly patients, preferably not to go into hypoglycemic coma, and with which will induce myocardial infarction, or the patient is going to brain damage. And also, any cases of hypoglycemic coma will induce more early dementia. The senile dementia will be early. So we must try in ICU that there should be no hypoglycemic episode, and also late night when the doctor is going to sleep or the sisters are nearly in the drowsy state, one must confirm the blood sugar level so the patient will not go into hypoglycemic coma. That is very, very important.
Absolute true, sir. Absolute true, sir.
So now comes Dr. I would invite Dr. Akash Kumar Singh, Senior Consultant Medicine Diabetology, Non-Interventional Cardiology, Bhadra, for talking on diabetic dyslipidemia. Please.
I thank the chairpersons. I will start my talk on diabetic dyslipidemia. Now, diabetes reduces life expectancy by 7 to 10 years and is a major cause of, CVD is a major cause of death in diabetes. If you see patients of MI who had previous MI and patients with diabetes and follow them for 7 years, the incidence of future CVD risk is similar. So that is why diabetes is said to be CVD risk equivalent. Now, diabetes and lipids, these are two of the major modifiable factors for prevention of CVD. If you see diabetes and dyslipidemia, they are major risk factor for carotid and coronary artery disease. If you see the lipid levels in patients who are non-diabetic and diabetic, the same lipid levels will have, confer higher risk of CVD in diabetic population. Now, this was a ICMR in-depth study which you all know, and diabetes and pre-diabetes is very common, and lipid dyslipidemia is also very common. So these are two of the commonest prevalent lipid disorders. Dyslipidemia is very, very common, and diabetes is also very common. Now, if you see the diabetes population, almost 85.5% of the males and almost 98% of females are suffering from dyslipidemia. So dyslipidemia is ubiquitous in patients of diabetes. If you see the urban and rural population, in both urban and rural population, diabetes and dyslipidemia are almost equivalent. So it is a myth that the rural population has less incidence. Worldwide also, if you see, then diabetes alone is very less, and diabetes with dyslipidemia and other comorbidities is a major chunk of cases. If you see the awareness, treatment and control, the awareness is less, treatment is even less, and the control is abysmal. Type 2 diabetes basically causes hyperglycemia, hyperinsulinemia, insulin resistance, which leads to endothelial dysfunction, diabetic dyslipidemia, inflammation, and atherosclerotic cardiovascular disease. Now, triglycerides basically are the storage forms of lipids in fat tissues. They comprise of fatty acids and glycerols. Fatty acids by themselves are very toxic, and therefore with glycerols they are stored as a storage form of lipids. The lipoprotein lipase enzyme basically breaks down triglycerides to fatty acids and glycerol, and in cases of insulin resistance, the activity of lipoprotein lipase increases, and so triglycerides broken down to free fatty acids and glycerol, and there is increased spillover of free fatty acids in the circulation. Now, liver is a major organ playing a role in this dyslipidemia if such situations as described earlier develop. So, increased free fatty acids, increased insulin resistance, and increased activity of lipoprotein lipase. This is a vicious cycle. Now, with increased free fatty acids, the liver is flooded with free fatty acids, increased triglycerides, VLDL in liver, and that leads to NFLD and NASH. Now, there is an enzyme called as cholesterol acetyl
transfer protein, and this basically transports the triglycerides from HDL, LDL to VLDL, IDL. So there is a bidirectional transport of triglyceride through these enzymes, and because in patients of insulin resistance, there is increased transport of triglycerides in the LDL, so the LDL becomes triglyceride rich, which and converts to small dense LDL, and this is because it is small, it percolates in the intraepithelial spaces, endothelial spaces, and leads to more atheroma formation. Now this small dense LDL is there is more oxidation, so we have more oxidized LDL, which causes unstable plaques, and there is an increased glycation of LDL, which is not recognized by the LDL receptors, and therefore the levels of increased this glycated LDL in the circulation increase. Now HDL also, there is an increased triglycerides transfer to HDL, and that leads to conversion of HDL to the small dense HDL, which has more triglycerides, and this has decreased circulatory time, this has decreased scavenging properties, so the atheroma scavenging is the property is decreased, and it is also cleared early in the circulation, so there are decreased HDL levels. So if we summarize the lipid abnormalities in diabetes, VLDL is increased because of increased production of triglycerides and ApoB, decreased clearance of triglycerides and ApoB, and abnormal composition. LDL, basically there is increased in triglyceride enrichment and increased small dense oxidized glycolated LDL levels. The HDL also is decreased, and there is increased amount of small dense HDL levels, which is also dysfunctional and loses its property of atheroma scavenging. Now HDL cholesterol, the therapies to HDL cholesterol have not been successful. So by and large in today's world, HDL cholesterol is a marker of future atherosclerotic cardiovascular disease. So it is used in risk stratification. Now in diabetics, the LDL basically has poor predictive power, and we use more of the non-HDL cholesterols for prediction of future atherosclerotic cardiovascular disease and CVD events because triglycerides are elevated. So presently non-HDLC is the second therapeutic target. It is estimation of total number of atherogenic particles, that is VLDL, ILDL, LDL, calculated easily as total cholesterol minus HDLC, relates well to ApoB levels, need not be a fasting sample, fairly reliable, and correlates very well with clinical events, better risk stratification compared with LDLC, in particular where there is raised triglycerides. The levels are generally 30 milligrams above the LDL targets. So if you see the correlation of non-HDL with the CVD, you can see as the levels of non-HDL increase, there is more chances of triple vessel disease. Now coming to triglycerides, triglycerides are relevant measure of evaluating CVD risk. Fasting levels generally desirable is less than 150, and contrary to the ADA thing that they are not related to CVD, increase the triglyceride to HDL ratio is a very, very important marker of metabolic syndrome. Now ApoB is a major atherogenic lipoprotein in the families of VLDL, ILDL, HDL, but it is a very good estimate, and it is the ultimate target for the control for prevention of CVD, but logistics are difficult, it is difficult to estimate, and therefore it is not much used, and instead of this, non-HDLC is used. So if you see the APO molecules, the APO A, B100, APO, they basically are atherogenic lipoprotein molecules, and the APO A basically are the protective molecules. We also have remnant cholesterols, which are chylomicrons, and the remnant cholesterols, which also are targeted. Now coming to lipo A, this is also very important genetic modification of LDL basically, and very important in Indian subsets. Once you have LDL and non-HDL in control, and if the still you have high CVD resistance, you should estimate this, and more than 30 milligram is very significant in Indians, although more than 50 is considered significant in Europeans. So you also have to look for LPA in your patients of CVD. So if you see the salient features of Indian diabetic dyslipidemia, high prevalence of dyslipidemia, low HDL levels very prevalent, LDL levels more than 100 very prevalent, presence of various dyslipidemia has increased over the past 30 years, population levels of mean total cholesterol, LDL cholesterol, and triglycerides are increasing, high prevalence of atherogenic dyslipidemia and metabolic syndrome, propensity for dyslipidemia is noted at younger age, awareness and treatment is abysmal, genetic and lifestyle measures both are important. And there is personal, medical, endocrine and metabolic reasons for this dyslipidemia. So if you see the patients of diabetic dyslipidemia, we have to risk stratify this, and the severity risk assessment in diabetes depend on duration of diabetes, associated risk factors, and dyslipidemia is a major risk factor, and target organ damage. These three will comprise of the risk factor assessment in patient of diabetic dyslipidemia. Now coming to the ADA recommendations, ADA recommends lipid screening in all patients who are freshly related to diabetes, and they say that once you started statin therapy, that after 4 to 12 weeks, you see the lipid levels again and then titrate the therapy. They advocate the triglyceride levels less than 150 as a target basically. Regarding the LDL, they advocate less than 100 as a target and less than 70 and less than 55 in the cases which require so, and therefore majority of the patients of diabetes qualify for therapy of dyslipidemia. The treatment strategies are lifestyle modification, pharmacological interventions, combination therapy, monitoring and adjustment treatment regimens, and we also see the future therapies. Now this is the paradigm of management of severity risk patients of diabetes, and you can see that the lipid management is one of the pillars. You also have to use agents which decrease the cardiovascular and kidney benefits, which are SGLT2 inhibitors and GLP-1 receptor agonist. Now the other modalities of treatment are basically a healthy lifestyle in the form of Mediterranean diet, ingestion of herbal components, physical activity, exercise training, and this all leads to improvement in the dyslipidemia part. This is the MNT part, of which I will not go in much detail, but you have to restrict the carbohydrates, and trans fats should specifically be taken care of, increase the dietary fiber, increase the vegetable, nuts, fruits, and the sugar and sugar sweetened beverages are a strict no. The other modalities of lifestyle modification are exercise, moderation or restriction of alcohol or cessation of alcohol, cessation of smoking, tobacco, maintenance of ideal body weight, yoga, meditation, and adequate sleep. Coming to the primary prevention, we will see the ADA guidelines for patients with aged 40 to 75 without atherosclerotic cardiovascular disease. Use moderate intensity statin therapy. For patients between 20 to 39, if they are associated risk factors, it is prudent to use the therapy, because this therapy will go a long way in decreasing the risk of future severity, and they will benefit more. For patients with 40 to 75 at high cardiovascular risk, you go for a LDL target of less than 70. Coming to the for patients between 40 to 75 at higher cardiovascular risk, especially with those with multiple atherosclerotic cardiovascular disease risk factors and LDL level more than 70, you add ezetimibe or you can add PCSK inhibitors to decrease future cardiovascular risk. Patients with diabetes more than 75 years already on statins, continuous statins, patients more than 75 who have accelerated risk of CVD, you should talk to the patient and try to initiate moderate intensity statin therapy, and statin therapy is contraindicated in pregnancy. Now coming to the secondary prevention, for patients of all ages with diabetes and atherosclerotic disease, high intensity statin therapy should be added to lifestyle therapy, grade A recommendations. For patients with diabetes and atherosclerotic disease, treatment with high intensity statin therapy should target LDL reduction more than 50% of from baseline, and if the existing therapies are unable to achieve this, then you can add ezetimibe or PCSK inhibitors or other therapies, as we will discuss. For individuals who do not tolerate or the intended intensity, the maximum tolerated dose of statin should be used. So if patient has intolerance to statin therapy, use the maximally tolerated dose of statin, or you can add another brand of statin, another type of statin, or if it is not possible, then you manage the lipids with lower dose of statins, whichever is tolerated, along with bempedoic acid, ezetimibe, PCSK inhibitors, and other drugs like inclisiran. Now combination therapy, now like diabetes, we also manage the lipids in the same fashion. If you feel that the statins would not be able to decrease the lipid levels to the desirable goals, then you can from the word go ahead with the combination therapy, and the combination therapies are statins with ezetimibe, statins with bemperoic acid, you can add PCSK inhibitors, and if the other options are inclisiran, which also can be used. Now, ADSA does not recognize triglyceride much as a CVD risk factors. So it says that statin plus fibrate combination therapy has not been shown to improve atherosclerotic cardiovascular disease outcomes and is generally not recommended. What they recommend for high triglyceride is molecules like EPA. Now with ezetimibe and bemperoic acid, if you use this combination, you can achieve a LDL reduction of to the tune of 35 to 40%. PCSK and inclisiran basically are two therapies which basically inhibit the PCSK9 protein and therefore upregulate the LDL receptors, and there is increased clearance of LDL from the circulation, and you can have an additional 60 to 70% LDL reduction with these therapies. So these therapies should be considered if the highest dose of statins along with the other agents fail to bring the LDL levels to the desirable levels. Now treatment of other lipoprotein fractions or targets for individuals with fasting triglycerides more than 500, treatment is recommended to decrease the risk of pancreatitis. If the LDL is in between, that is 175 to 499, you should try to find out the secondary causes and treat them, and the treatment should be, the first line they have recommended is EPA. Now EPA basically lowers triglycerides and used as an adjunct to diet and statin therapy. The dose is 4 to 8 grams per day, but there are concerns of heavy metal mercury contamination if it is not sourced from a reliable manufacturer. Fibrates also have lower triglycerides, and in the field trial have been shown to decrease the risk of future coronary events by 11%, but not favored much by ADA. Saraglitazole, an Indian molecule basically, which takes care of the high triglycerides in patients of diabetic dyslipidemia. So this is how you deal with high triglycerides. I will not go in detail because of paucity of time. We have already discussed. Other therapies are niacin, not proved to be effective. Presently, CETP inhibitors, which upregulate the HDL levels but not proved to be effective. Bariatric surgery may be offered to some patients which are indicated, and it aids in weight loss, diabetes control, and dyslipidemia. There are additional therapies, but lastly, we will see the LPA lowering therapy, which are being in phase 2 and phase 3 trials, and the molecules are olpasiran, leposiran, zilabesiran, and muvaleptin basically. And the most the advanced stage development is in pelageseron and olpasiran. They lower the LPA levels by the 80 to 100% depending on the dose, and the muvaleptin decreases the LPA levels by 60%. We still do not know the optimal levels to which the LPA should be lowered basically. So once we know the optimal levels to which the LPA should be lowered, we can use either of these agents. So in patients with established type 2 diabetes, elevated LPA levels contribute to increased ASC risk. Clinical outcome data suggest a beneficial effect of LPA lowering on CVD endpoints in patients with type 2 diabetes. More studies are needed here, and phase 1, phase 2, phase 3 trials are on. So to summarize, majority of the Indian patients with diabetes have dyslipidemia. Insulin resistance contributes to this characteristic diabetic dyslipidemia. Propensity to develop atherosclerotic cardiovascular disease much higher in these patients, also caused as atherosclerotic diabetic dyslipidemia. Disturbance of lipid metabolism, early event potentially preceding the disease by several years. Monitoring of the conventional LDL-C may be misleading in diabetic patients, requires specific monitoring. Non-HDL-C has emerged as a very useful investigation and correlates with the ApoB levels. Risk stratification of these patients is required to decide treatment goals. Depending on the extent of LDL reduction required, combination therapy may be initiated from the beginning. Novel emerging biomarkers are ApoB and lipoprotein A. There is a lot of research in this field to find out newer and newer therapies. Thank you.
Thank you, sir, for your extensive elaboration. Yesterday in the workshop, we had a 3-hour extensive diabetic dyslipidemia workshop. So thank you, sir. We're getting late for the oration, so we'll end this session. Thank you all.
Thank you, everyone. My humble request to all the chairpersons and the speakers to proceed to the memento bay for the memento giving. Please. Coming to the further scheduled session, the chairman's oration. Ladies and gentlemen, let's welcome the chairpersons of the session. Dr. Niranjan Tripathi, past chairman, RSSDI Odisha, senior consultant physician, Cuttack. Dr. Lalit Kumar Meher, professor of medicine and advisor, IMS and Some Hospital, Bhubaneswar. Next in line, Dr. Sisir Kumar Mahapatro, senior consultant physician, Bhubaneswar. I request all the chairpersons to please be seated on their respective seats on the stage. Sirs, please. Now, I'd like to extend my warmest receptions to the orator, Professor Dr. Jayant Kumar Panda, Chairman, RSSDI, onto the dais. Sir, please. My noble request to the chairpersons on the dais to felicitate Dr. Jayant Kumar Panda and carry on the 7th scientific session. Please. Thank you, everyone. Now it's over to the chairpersons to proceed the session. Thank you.
My utmost respect to all the chairpersons. Professor Tripathi is perhaps senior most physician, so active in the conferences, medical education and fellowship. Professor Lalit Meher is my direct teacher, undergraduate and postgraduate, and I have worked all throughout and learned many things from him. Shishir sir has served as a President API ODISHA, President or Chairman RSSDI ODISHA, and encouraged and exemplified good brotherhood amongst all. And in the auditorium, we have President RSSDI, Professor Rakesh Shahai, who is again part of the family, and we have Professor Anuj Maheshwari, who is the Vice President, and again part of the family. We have Professor R.K. Dalai, my teacher, Dr. Bharat Panigrahi, Professor Surendra Shwai, Dr. Sheba Acharya, Karthik sir, RN sir, and then Professor Ashok Singh, I see, my teacher, has come all the way from Shambalpur, and all are not only my teachers, seniors, they love from the heart, and it's my responsibility to work for the people of Odisha, for the speciality, for the subject, for the cause, so that in the national level we can showcase our own soil, our own faculties, our own interest. So that is the motto in which we are working for last 25, 30 years. So I kept this topic a non-medical topic for all of you, so that you can know how RSSDI Odisha was born and moved till last 12 years. So I'll be brief. For the organizers, I'll save some time because we are running late, and then I'm sure all of you will have a rough impression how we went about. So we have already conducted 3 national conferences. The first national conference was in 70s in a lecture theatre of SCB Medical College. The second was allotted in 1999 when the super cyclone took place, and it was rescheduled to February 2000. And this conference, the national conference 99-2000 in Bhubaneswar, was conducted with only 261 delegates, national conference with 261 delegates, and at that time the RSSDI national events were catching 200 to 300 people only. Same year we had another conference in Mumbai, that was the normal conference in the month of November, and the next year, 2001, it was in Chandigarh, and 2002, it was in Kochi, where Professor Siddharth Das was the president of RSSDI. So first time I participated in RSSDI conference in 2000, when we hosted the conference. I was a member of reception committee. I was part of the conference because I was working with Professor Das, and that made me interested towards organization. I was as such interested in diabetes from the beginning. I was not interested in endocrinology. I was interested in diabetes because diabetes has multiple facets for the physician, multiple challenges for the physician, and I had my love, my passion for the cause, and I thought this is the right forum I should join, and I became a member in 2000, around 25 years back, and started my contribution of free papers, chapters and research projects in the organization. Then came 2011, when I joined. Dr. Alok Kanungo was here. I think sir is there around. Dr. Alok Kanungo was the member executive committee from the East Zone, and after that it went to Shubhankar Chaudhary from Calcutta, and 2008 I contested with Shamar Banerjee and lost the election. And 2011 I could take the responsibility of member executive committee from the East for 2 terms. That was from 2011 to 2016. And 2016 I had the opportunity of serving the organization as the treasurer, and when working for the national conference and deciding in the national EC, we all had a dream of hosting the conference in our own state. But there were issues. After the national conference in 2000 itself, 2 state chapters were proposed. One is Odisha, one is Maharashtra. So Odisha is one of the first state chapter to be proposed by Professor B.B. Tripathi, and the rule was 50 doctors had to shine, and I was the only doctor I remember, as told rightly, to sign the document of forming a state chapter way back in 2000, but the account was not open and the activity were not started. This continued till 2013, when we thought of reviving the RSSDI Odisha activities under the leadership of Professor Siddharth Das. Professor Das is not here, he is sick, but with his stewardship, with his leadership, we started the activity, and 2013 had first RSSDI in Cuttack, where doyens like Professor B. Mohan, Dr. Shadikot, Dr. Sheshaya, and the whole team of national faculty joined, and RSSDI activity started in Odisha. Thereafter, we had second RSSDI in Rourkela, third in Bhubaneswar. I'll show you some photos of fourth RSSDI in Puri itself, and you'll see in just 4 years, 13, 14, 15, 16, the volume went, and we had a similar conference with 1,000 delegates, and you'll see how we organized, and Honorable Governor, the then Governor, Dr. Jamir, came and inaugurated the conference. After that, the success story continued. Professor Surendra Swami is here, he was the president. Shishir Mahapatra sir was the president, and series of programs in Cuttack, Bhubaneswar went, where all of you have participated and contributed yourself. Then came the first meeting was in IMA House, and first RSSDI there, and then came the turn of hosting the national conference. All states have a dream of hosting. I had good friends like Anuj, Rakesh. Anuj hosted the 2015 conference in Lucknow with much challenges. All facilities were not there, and there we got the strength. We can also host. I remember Dr. Jitendra Singh and me were used to demand to have the conference at the Jammu and Bhubaneswar in the EC from the beginning. He got elected and he could not demand further, but we had an opportunity. In spite of all challenges in the Bhubaneswar, the National EC was kind enough to allot the conference. We hosted, giving our best, and it is one of the most appreciated conference in many minds till now. In 2023, the committee decided to propose me as president-elect. I had no dream, no desire. I have served as secretary, I have served as vice president, and my name was proposed, and I got the opportunity to serve the organization as chairman. We never strive for power, but when a responsibility comes, we try to give our best for all our delegates, for our faculties, to promote good shines. With this short history, I'll show you some brief photos and the videos. I could not collect all which are there in my hard disk, but because of this workload, we could collect few, and that will refresh your memory and will save some time for our sessions. This is what I was telling. Our fourth RSSDI 16 in Hotel Blue Lily, where Honorable Governor and Madam Governor were there. H.R. Arvind sir was the President RSSDI then, and Pramod Acharya sir was our chairman reception, even in national conference. He was there. Professor Dash is here, and a whole lot of delegates. The hall was full. You'll see here in this video that how
it's a great pleasure inviting you all for this 4th RSSDI ODISHA 2016, and rightly many of well-wishers have sent the message. Now all the roads in diabetes care in Odisha leads to Puri, because people from all corners of the state and different districts have joined here, and the number of registered delegates has crossed 700, and along with the associated delegates, we are reaching almost 1,000 people in the event by tomorrow. We at RSSDI, having the motto of updating the physicians to face the challenge of diabetes, which is ever increasing. There is a lot of progress in science, but still we have failed to tackle the comorbidities, complications, and number of patients coming up with diabetes. The research is going on, and ours is a primarily research society for study of diabetes in India, and primarily we encourage the researchers to find out more and more facts regarding the diabetes diagnosis, management, and prevention of complications. After we revived the state chapter in 2013, which was formed way back in 2000, we conducted 3 successful conferences and encouraged many of our members in the state to become the members of RSSDI, and the membership has crossed 300 at present in the state. At Bhubaneswar last year, at Rourkela in 2014, and Cuttack in 2013, we had more than 600 registrations telling about the popularity of the organization and interest of the physicians towards research-based study. We have conducted a midterm CME in the month of March at Talcher, which was organized by Dr. Sanjay Dash and attended by more than 100 delegates from all over the state. And also we organized a walkathon successfully from SU Medical College to the historic Baravati Fort on last World Diabetes Day in presence of Honorable Member of Parliament and the Hollywood superstar Shri Anubhav Mohanty and Mrs. Barsha Mohanty, who attracted a crowd of more than 1,000 and created a awareness in the state for weeks together.
So that was the story almost 8 years back in the same soil, and we are repeating that story with more number of delegates, with more number of faculties and more facilities in a bigger property.
Day after, the chief guest, the Honorable Governor of Odisha, His Excellency Dr. S.C. Jamir, along with his better half, arrived at the venue and was received cordially by the dignitaries of RSSDI. The conference was formally inaugurated by the chief guest along with the officials of RSSDI by lighting the lamp and seeking the blessings of the Almighty God Jagat.
And the next day morning, we had walked in the sea. The sea you see in front, and morning you see how beautifully
Again in the
beach work can be
morning
done.
of 25th September, the dynamic secretary Dr. Jayant Kumar Panda, cine artist Mr. Kuna Tripathi, Dr. Niranjan Tripathi, many more doctors and volunteers gathered for a walkathon on the beach for an hour. The participants of walkathon offered their original views on diabetes and importance of regular work linked to this disease.
So, we felicitated Professor R.J. Dash, a legend, and inaugurated the souvenir in that function. So in Puri, 8 years back, the legacy was there, and it's repeating after 8 years. And you'll be happy that the journey has increased. Our membership number has increased by 1.5 times, and you all will contribute further by becoming member and actively participating. Then the small story of 2017, we had the team, we started the preparation, and the team members here and the preparatory meeting here, the best of the effort was given. Most of them are still contributing and active in our team, and we gave our little
To
effort.
what extent we can dare and fight in a war field. So to make this logo, it was a challenge because wherever you go, there is a picture that the person is beheaded, because that is from the monarch. Monarch, the person is beheaded, and to get a man with a exact shape, my photographer, this photographer only, in a raining evening, who went in Master Canteen Square and took the photographs, and finally that was made, and logo is prepared in hours before the Hyderabad conference brochure was printed. Yeah. So this is the logo we have blocked, and the dates, with much discussion with the local team, Shobhagya.
So that's regarding the deciding a logo for the conference. The Master Canteen Square horse was photographed, and a logo and the memento was designed, which was the suggestion of our present patron and the then organizing chairman, Professor Siddharth Das. You can see many of the faces who are here. And the
IMA Malashore, we are having stall, and from there we are giving registration and gift like the Alibad, Hyderabad. So the picture below you can see Dr. K.C. Sahu is there, Dr. P.C. Sahu is there, and Sandeep is there, Dr. Goenka is there, Dr. Raju is there, and Shantosh, Manoranjan, Nilmadhav, all are there. This is a picture from the Hyderabad stall when Alibad started. So I think, is there any more slide now? So that's what all we have done till now. It's not that we have stopped working. We are continuously working every day, and in the further discussions, you can see what all have been done. And
so that is regarding our stall at Hyderabad. I remember Rakesh gave us a very good place, and we had registered almost 600 delegates as an early bird registration at the Hyderabad site for the national conference. And this is the press meet we conducted.
See, in terms of the hall management, we have to take it on gen sets, and for entertainment and other, we will be looking for the raw power. So that we have to coordinate with the sir.
There are two things. What is the sales connect? The public area will be with the raw power, and the generator will be all the halls will be back over the generator.
Yeah.
Say backup and functioning.
Function.
So no generator. So what generators are use ones?
Sir, see, normally we use, there are multiple generators, so sir, I cannot give the technicalities because I'm not the technical person. So I would not be the right person.
that will be given to the AV for people.
That would be given to the AV people, audiovisual people.
This is a very contentious issue which we settle now. So we'll apply to the GRIDCO or CESCO for giving us power, putting fixing meters for the utility areas. And the halls will be provided by electric power on gensets. And they are also, they have a backup generators.
The journey was on, and you all were the part of the event, and you have participated, enjoyed, meeting after meeting, decided the participation. The organizing photos are nostalgic, and the whole national team was there with us for the site evaluation and the deciding the conference proceedings. This is with Mayfair team and Witchcraft team. And you can see the whole national executive. Professor Sarita Bajaj was the then president, and Professor P.V. Rao was the president-elect. Dr. Breeze Makkar is here. He was the secretary, and the whole team here, and there are many known faces to all of us. We went around and decided our integrities. This is the inaugural function and the issue in the meeting, and after that the series of conferences. This is Katak, this is Bhubaneswar, and then so many programs have taken place. I'm not taking you further. All are there in your memory, all are there in your mind. So just this is to refresh that how much of effort is given to start RSSDI activity in the state, and all of you have contributed in individual capacity to that. So as a chairman, we are enhancing the membership. We are appealing all of you, especially the youngsters who are not member, to become a member. Start a research project. Our national president here, he'll be speaking and he'll be attending our inaugural function as chief guest. We have Professor Anuj Maheshwari, who is our vice president. We have many national faculties who are part and parcel of RSSDI. We have many state leaders, and I am sure with their presence, their encouragement, with the background of the Odisha, Professor B.B. Tripathi, Professor N.C. Panda, Professor Siddharth Das, Professor R.J. Das, Professor Pramod Acharya, Professor Keshi Shamal, all have contributed immensely, whom the whole country, whole world knows. But the number of research projects, publications, contributions, and organizations are coming down. So I expect, again, you all will be there in the race. That's why I kept a theme of de-diabeting Odisha. Let us de-diabetes Odisha, de-diabeting Odisha. The effort starts with a project to aim at the country. So the number should not go on when we all are so active, promoting lifestyle, promoting drugs, promoting treatment, promoting the awareness of diabetes among people. I'll not take much time. I must thank you. This is the midterm CME Keunjhar, which was excellent under the organization of Professor P.K. Thatoi, and this conference will be, you are watching yourself, and will give you a impetus regarding the event and the RSSDI Odisha. So with this, I appeal all of you to be a part of the movement and welcome you. It's your organization. Come, have a project, contribute, register, and I'm sure together we can go forward. Thank you for the time.
Chairman needs standing up. Thank you, Dr. Jayant, for giving us a very sweet glimpse of your great journey to fight against diabetes. In fact, each and every one in this hall must have realized by now your organizational skill, your passion for the subject, and your tremendous endeavor to fight against diabetes. And but this morning I'm so proud, in fact, that I have been a part of life of Dr. Jayant in shaping his career. So I am really, really very, very proud today, and it's a very great moment for me, in fact. And I know that this journey, you are on the way of this journey, a lot of path you have to travel, and I wish and I pray, Lord Jagannath, the whole of your journey should be filled with flowers, lot of accolades, and lot many sweet stories, lot many success. Thank you all very much.
I heartfully thank all the chairpersons of this session and our orator, Professor Dr. Jayant Kumar Panda. I request all the chairpersons kindly proceed to the memento bay for the memento giving. Now, moving ahead, we would like to invite the chairpersons for the Professor Dr. Siddharth Das oration, Dr. Prasant Kumar Misra, Katak, Dr. R.K. Dalai, Katak, Dr. A.K. Baliyar Singh, Katak, Dr. Kaushik Misra, Puri. We extend our cordial invitation to the orator, Professor Dr. Rakesh Kumar Sahai, President RSSDI, onto the dais. I request the chairpersons to kindly felicitate our esteemed guest, Professor Dr. Rakesh Kumar Sahai. I would like to request all the chairpersons to kindly felicitate our guest, Professor Dr. Rakesh Kumar Sahai. Over to the chairpersons for the further proceedings of this oratory session. Thank you.
So, esteemed delegates, I welcome you all to this holy land of Lord Jagannath. It's a pleasure on my part to chair this session with my teacher, Professor Mishra. Now, I am privileged to have a chairperson in this most prestigious oration, that is Professor Siddhartha Das oration. What Dr. Jayanta told, the role of Professor Siddhartha Das in shaping the diabetes in Odisha. After Professor B.B. Tripathi, Professor Siddhartha Das single-handedly took the burden of diabetes in Odisha and took it to the national and international field. Diabetes is a passion for Professor Das. He has devoted every minute of his time for the sake of diabetes, the research and popularizing diabetes in the remote corner of the country. His research and his dedication in the field of diabetes is commendable. He is known as the doctor of research and innovation. His contribution as lean diabetes type 2 diabetes and the MRDM or MMDM, as you tell, is almost legendary and has accepted at national and international level. So whatever I will tell about Professor Das will be less. But I am fortunate enough to be a chairperson in the name of Professor Siddhartha Das oration, where Dr. Sahai is the best speaker that has been chosen by Dr. Jayant Panda, who will give justice to this oration. I request Professor Mishra to some lines.
Well, I was a medical teacher from 1977 to 2009. We have many students, very many beloved students, and Siddhartha is one. Jayanti is another. Dr. Padhari is another, like that. I am proud of them. Now, coming to the subject proper, I know Dr. Sahai. I had been to Osmania Medical College when, as MCI inspector, to open up the department of endocrinology here. when he was probably in the post of assistant professor. Okay, it's a pleasure that he has gone up and he is with us. Now, what is the interest in the management of thought process of type 2 diabetes in first year of diagnosis? Even though the latent period is many years, 3 to 11 years. But the clinical diagnosis and first 1 year of the management with a special thinking helps the patient in the long run. And I think we are going to hear from Dr. Sai the same thing what I said.
Thank you, Professor Saab. Professor Saab probably doesn't need any recognition. And Professor, he is Professor of Endocrinology in Osmania Medical College Hospital, Hyderabad. He is the President of Research Society for Study of Diabetes in India 2024. President South Asian Federation of Endocrine Societies. He has published over 180 publications in various national and international journals with 5,800 citations and indexes. He has authored chapters in various textbooks and monograms in diabetes and endocrinology. We are proud of you, sir. So you can continue with your deliberation.
Thank you, sir. Thank you very much for the kind words of introduction. Thank you to both the chairpersons. Dr. P.K. Mishra, as he has mentioned, he was at our institute almost 21 years back to do an inspection for starting the course in DM endocrinology at our institution, and we were very thankful for him for giving a very favorable report, and we had from then we've been having a DM endocrinology course going on in our college, and he has been also the examiner for the same course many times at our institution. As regards Professor Siddharth Das, as was mentioned, that he is a great personality in the field of managing diabetes in the state of Odisha and all over the country itself. Actually, nationally, he has been very active with the RSSDI, and he has also been a patron of the RSSDI. He is now currently the patron of RSSDI and also the past president of RSSDI, and he's been very actively involved with all the activities of RSSDI. So his research, as has been mentioned by the chairperson, is mainly in the field of lean type 2 diabetes, malnutrition related diabetes, and I've heard him speak a lot about lipid abnormalities in diabetes. I think these are the major areas that he has been working on. So I would like to start by paying my regards to Professor Siddharth Das, who could not be here today. He sent his wishes and blessings to me and mentioned that he was unable to attend this meeting today. So I thought that today, to keep the topic, to keep it relevant to the occasion, I thought that I will speak on what is the importance of first year of diabetes, why it matters, how does it matter, does it really matter that we should manage diabetes effectively in the first year of diagnosis, and how to make it matter. Because what we have seen is that most of the time, diabetes is a silent disease, as we know that, most of the times people don't know that they have diabetes for several years and they present with complications. Half of the people with diabetes do not know about their disorder, and they come to know only when they develop complications. Those who are fortunate to have a diagnosis early should actually be effectively managed, because what happens generally is that we tend to be a little little lax in managing such patients, because we think that, oh, they've just developed diabetes. What is the importance of this early aggressive management of diabetes has become very important, and that's what I would try to present in the next few minutes. Next about 15-20 minutes, I will try to show the importance of effective management of diabetes in the initial period of diagnosis, how it makes a difference in the long-term outcomes, and what should be done. So let me just start off with, a patient. These patients are the ones which we see. Maybe 20 to 30% of our practices with patients like this who are, just detected to have diabetes. This is a 30-year-old gentleman who was otherwise asymptomatic, who went for a routine check, and he finds that his blood sugar levels are high, 224, 354. He is having HbA1c of 10.4. His lipid abnormalities are there. His blood pressure is also high, and he's gone for a routine annual checkup. He's not having any symptoms, and he comes to you, and he may also have talked to many of his colleagues and friends, and who tell him that nothing to worry, don't take any medication, or he may be going to many non-conventional therapies, and so many things may happen. So what do we advise? Would you like to just tell him that, okay, just make some changes in your lifestyle, come back after a year? Or would you like to initiate him? Some of us may say that, oh, let's start him on, 3-drug therapy. Somebody may say that let's start insulin and then change to oral anti-diabetic medication. Some may, think. So all these approaches are okay. I mean, I think the first one should not be the thing that we should do, because we know that today we should be able to should effectively manage the individual rather than leave him without giving him adequate advice about proper management. So another individual like this, if you look at this lady who was again having a similar presentation, and she's advised lifestyle and metformin, she doesn't want to take any medication, she's not willing to come for follow-up also. So these are the usual scenarios that we're seeing. That's the reason why I'm speaking about this, because these are many individuals that we are seeing in our clinical practice, and they are not taking not being effectively managed, although because they are highly educated, still they are not adhering to the management algorithm that we would like to follow in these individuals. So if you look at the problem of diabetes, we see that the problem is growing every year. We see that the number of people with diabetes is increasing worldwide. Today we have more than about 550 million people with diabetes, and out of that 1/5 of them are in India only. We see that we have about more than 100 million people with diabetes, and if you look at the problems associated with diabetes, it leads to about 1.5 million deaths across the globe are caused because of diabetes, and 48% of these are occurring below the age of 70 years. And diabetic kidney disease and cardiovascular disease in diabetes are the major killers for these individuals with diabetes. So if you look at the burden of diabetes, all of us are aware of this, 11.4% from the recent INDIAB data. We know that about 15.3% have pre-diabetes, and almost half of them are not aware that they have diabetes. So these are based on the data collected by doing a stratified randomized survey, as you would call it, and half of them actually do not know that they have diabetes. So they may end up with complications. And when you look at the metabolic comorbidities that accompany diabetes, we see that they are even significantly present. That is abdominal obesity, dyslipidemia, whether you look at the total cholesterol levels, or whether you look at LDL levels, or if you look at low HDL levels, I think that is even higher. Almost 80% of individuals have that. And blood pressure, high blood pressure is also very common abnormality which accompanies diabetes. And the major complications of diabetes we know are because of either the microvascular complications or the macrovascular disease. All of them have become very important causes of, when you look at blindness, the most important cause today is diabetes. When you look at amputations, non-traumatic amputations, diabetes is the leading cause of that. And when you look at the macrovascular disease, cardiovascular disease accounting for majority of the deaths in people with diabetes. And we have various manifestations in the cardiovascular disease, whether it is the heart manifesting with the heart involvement in the form of CAD or development of heart failure, or whether it is in the form of strokes. And then there is coexistence of these complications. It's not that these complications occur in isolation. People with atherosclerotic cardiovascular disease have a high risk for developing CKD, and they also have a high risk of developing heart failure. And we have effective therapies for all this, and so therefore we should see that we prevent these problems rather than tackling them after they have developed. So if we look at the pathophysiology of diabetes, we know that we have several different mechanisms. From the earlier days, maybe 30-40 years back, when our chairpersons were practicing in their earlier days, they had very few medications available, and today we have many more medications available, because we have identified different pathways contributing to hyperglycemia, and we have therapies for that. We have the incretin effect being identified, and we have therapies to tackle that. We know about the kidney, the increased glucose loss in the urine, and we have therapies to increase the glucose loss in the urine. We have all these therapies available, but central to all that is the beta cell failure, which is caused by by a genetic predisposition that we have towards a very rapid development of beta cell failure. Apart from that, the effect of glucotoxicity, lipotoxicity is there, apart from all the other factors that contribute towards the beta cell failure, which is very important. Now, when we look at the diabetes in Indians, we have our diabetes is different. We have different manifestation of diabetes. We have diabetes occurring a decade earlier. And this slide actually summarizes all this very elegantly in one slide. We can see the differences of diabetes in India. We are seeing diabetes occurring at least 10 years earlier at a lower BMI with a lower mid-arm circumference, meaning that we have less muscle mass. Sarcopenia is a very important contributor towards the development and progression of diabetes. And also we have greater abdominal obesity, greater insulin resistance, which are contributing towards the development of diabetes, earlier development of diabetes, and the different manifestations that we are speaking of during the whole conference. We have heard a lot about the differences between diabetes occurring in our population, this unique Indian phenotype that we speak of, that is in addition to the lower age of occurrence, early rapid decline of beta cell function, and abdominal obesity, and presence of dyslipidemia and dysglycemia contributing towards greater risk of cardiovascular disease in our population. And probably contributing to that is the rapid urbanization. Rural to urban migration is significantly contributing to this. So what I would just like to highlight is that we have a significant burden of complications. Whether you look at this is data from Dr. Mohan's group, his Chennai urban population study. He has followed up these individuals and shown that the prevalence of complications in millions are shown there in 2010. If you look at today's data, probably it may be more than double beyond what was seen at that time. And so therefore there is a significant burden of the complications, and this is what we have to, these are preventable complications which we need to look at, because we know that there is if you look at the natural history of diabetes, all of us are aware that insulin resistance is present for several years, and then insulin deficiency develops. And over the period of time after the onset of diabetes also, there is a certain period in which after which the complications become the microvascular disease starts with the onset of diabetes. Macrovascular disease may start earlier, but they are preventable in the early phases. After that, there is a steep increase in the risk of development of complications. So it is important that we diagnose diabetes early and we treat effectively so as to prevent the complications, because what we know is that diabetes can reduce the lifespan by almost 6 to 14 years when compared to people without diabetes. So, and particularly this is happening when people develop cardiovascular disease or renal disease, and that significantly reduces the lifespan of an individual who develops diabetes. So early intensive therapy for diabetes is very important. The first year of diabetes management is pivotal in setting the trajectory for long-term health outcomes. Early glycemic control, comprehensive education, lifestyle modifications, and providing psychological support and personalized care in the first year of diabetes, that is right at the time of detection of diabetes, is very important in terms of providing a good trajectory of having protection from these complications. The effort made during this period have lasting benefits, reducing the complications and enhancing the quality of life for patients with diabetes. So let us look at the evidence for this. The evidence for good glycemic control preventing the complications is seen right from the DCCT study, which was presented in 1993 itself, where in type 1 diabetics we could see that with 2% reduction in the HbA1c, we could see a 60% reduction in complications. In the UKPDS study, which was looking at type 2 diabetics, it is important to understand this UKPDS study because they enrolled patients right from the onset of diabetes, and from the first time they were detected to have diabetes, they were randomized to either intensive control versus a standard control. And we have seen that with 1% reduction over 10 years in the first 10 years, when they had a 1% reduction in the intensive control group, 1% better reduction in HbA1c as compared to the standard group, they had almost a 30% reduction in various complications. The cardiovascular complications did not come down significantly, but interestingly, when these people were followed up for the next 10 years, after that we had results, the data from the follow-up of this UKPDS study. When they followed up for next 10 years, we see that this benefit persisted, and in fact the cardiovascular disease actually was significantly reduced in those who were initially intensively controlled. Although, as you can see in the second part, where you can see that in the second part of their journey, the next 10 years of the journey after the first 10 years, the second 10 years of the journey, they were all having similar glycemic control. The ones who were intensively controlled earlier versus those who were conventionally controlled, all of them had similar glycemic control, but still they continued to enjoy the benefits of what they did earlier in the first 10 years. And that was called as the legacy effect. And more interestingly, what we see is that, so that was called the legacy effect of the metabolic memory, where good glycemic control achieved early in the natural history of diabetes had a long lasting effect. That was published in 2007 or 8, and that is almost about 15 years back. Now, interestingly, what we see is that when we have data of these same patients, when they followed up till 2021 or 2021, and this was published last year in NEJM, where the same cohort which was earlier, which was in the UKPDS, was followed up, and we see that almost now 40 years after their enrollment into the study, the group which was intensively controlled earlier continues to have the same benefits, continues to have those benefits still, although they may not be having the same degree of control. As you can see here in the third column, the first column was at the first 10 years, 1997. The second column is at 2007, and at 2021 you see that almost 17.4 years after the end of the study, that is almost 27 years into the study, I mean from the time they were enrolled, you are still seeing that they are having the same benefits. They are having microvascular disease reduction by 26%, lower risk of heart failure, myocardial infarction by 15%, which has statistically become even more significant, and any diabetes related endpoint by 10%, which again remains significant. So what we are seeing is that this initial early intensive glycemic control, whether it was whatever agent they used, earlier those days they used only metformin and sulfonylurea or combination of these two, or along with metformin, along with insulin, they appear to provide to confer a near lifelong reduced risk of death and myocardial infarction for these individuals who were intensively well controlled in the initial years. So this highlights the fact that achieving near normoglycemia immediately following diagnosis might be essential to minimize the lifetime risk of developing diabetes related complications to the greatest extent possible. So this is the important message that we get from this UKPDS study, that early management, early intensive management in the first year of diagnosis itself makes a lot of difference, sets the trajectory for a better life for this individual with diabetes. So these figures just highlight the same data from the 24-year follow-up of the UKPDS study. So I will not go into further details of that, but highlight the fact that the quality adjusted life years gained was even with the use of metformin versus conventional therapy was much better, and as you can see that using these medications did make a difference. So we have data from other studies also. This is the UKPDS study, but let us look at some recent data. This is from the group of Kamlesh Kunti and his colleagues, who have looked at who published this in 2017. What they did was they looked at people with diabetes. They retrospectively looked at their first year of diabetes, their control during the first year of diabetes. They divided them according to that into those who could achieve a HbA1c of less than 7% versus those who could not achieve that HbA1c of less than 7%. So as compared to those who had achieved HbA1c of less than 7%, those who could not achieve that at 5.3 years had a significantly increased risk of myocardial infarction by 67%, strokes increased by 51%, heart failure by 64%, and composite cardiovascular endpoints increased by 62%. So clearly what is seen is that in this study also, this was not a randomized control trial like the UKPDS, but this was a retrospective analysis also. This also a real world type of analysis, which again showed that early management of early effective management of diabetes, I mean you don't even have to say aggressive, early effective management of diabetes in the first year itself brought about a lot of difference to these individuals when they were followed up for within 5 years. You could see that there was a difference in their rates of development of complications. So this legacy effect is seen in other studies also. This was another cohort of 34,000 patients which were from US, And what we see is that they also spoke about this legacy effect. I hope the battery will last till for the next few minutes till I finish. So anyway, so what we are saying is that in this study also, this had almost 34,000 patients. HbA1c levels of more than 6.5% post-diagnosis led to higher micro and macrovascular events. And those with less than 7.7% HbA1c had increased mortality. So longer periods of exposure to HbA1c of more than 8% significantly increase the risk of microvascular events and mortality. So clearly what they have shown is that from 6.5% above, there is an increase in risk of complications, risk of morbidity and mortality. And maintaining HbA1c, the key highlight of this study was that maintaining HbA1c value of less than 6.5% during the first year post-diagnosis significantly reduce the risk of future complications. So again, once again, highlighting this fact that we are that I'm trying to emphasize here, that in the first year itself, if you are able to achieve a good HbA1c, because this is the time when patients have no other complications. If they have no complications, they are the ones who can be aggressively managed. They can keep a near normal blood glucose control, and they can achieve a HbA1c of less than 6.5%. Doing that will provide them a significant reduction in the risk of future development of complications. Early intensive management is crucial for new patients to prevent irreversible complications. So having looked at that, I'll just change gears a little bit and speak about the young diabetes, because generally what we see is that young type 2 diabetes is on the rise today. We often feel that they are better off than the type 1s because they don't require insulin, and the type 1s, we are worried about the type 1s, about intensively managing them using pumps and using all sort of CGMs and other devices. But the young type 2s generally tend to be less aggressively managed, and because they also don't require insulin, and they also generally tend to not effectively manage their diabetes. So what is this is on the rise across the globe, young onset type 2 diabetes, and interestingly, RSSDI had done the Defeat Diabetes campaign. So where we did the glucose testing for 1 million people across the country on one particular day. That was 29 September. That was the World Heart Day on 29 September 2001. We did across the country, or I'm sure all of you would have been part of the campaign where we did 1 million tests, and out of this we analyzed the data from and had good analyzable data on 235,000 patients. And after cleaning up, we did analysis, and we could include 225,000 data points in the analysis. And what we found was that in this analysis was that the prevalence of diabetes was quite high amongst those who were screened, because obviously these were people who came to the hospital for some reason or the other. So we had a 45% prevalence of diabetes amongst them. And interestingly, what is important is that if you look at the age distribution of these patients, you find that there are high prevalence amongst the younger age groups. So less than 35, almost 18% were less than 35, almost 18% were less than 35, 13% were in the age group of less than 30 years also, and less than 25 was 9.8, again another close to 10%. So the important point here is that a lot of young people are having diabetes in our country, and as we have seen that we tend to develop diabetes early, and many of them have young type 2 diabetics are very common in our country. And what we see is that if you look at the risk of these individuals, even without family history, they had a high prevalence of diabetes. With family history, the prevalence was much higher. So it is important that we start screening early and identify diabetes early in our population, because we tend to have early onset of diabetes. And this was the conclusion from that study. But coming back to this youth onset type 2 diabetes, what we see is that youth onset diabetes have a significantly higher burden of complications. So unlike what we generally assume, that is that they may not be having much of complications as compared to the type 1 diabetes, but what we see is that they are having significant burden of complications. This was data from the Today's study. Today's study is also looking at the youth onset diabetes amongst the population across US. And what they have shown in their study is that they tended to have a very high risk of complications as compared to, they compared them with type 1 diabetics and saw that they tend to have complications early, and they are having more of macrovascular disease, 22% as compared to 0% in the type 1 diabetics, 68% microvascular complications as compared to 27% in the type 1 diabetes cohort. So clearly showing that these individuals are at a high risk of complications, and we should not sort of be lenient, lax in managing them. We should have a more aggressive approach is warranted in young onset type 2 as compared to type 1 diabetics, because they have a higher burden of complications. So this is an important message that I wanted to highlight here. And then another study which I would like to highlight here is where we have looked at the cardiovascular risk amongst our population at onset of diabetes. So these were from different clinics across the country. We have looked at data on patients who were diagnosed right at the within 6 months of diagnosis of diabetes. We looked at their cardiovascular risk scoring as identified, as defined by the Lipid Association of India. They have given some scoring system for identifying for looking at the cardiovascular risk factors and looking at their cardiovascular risk. And what we found was that all the patients were at a high risk of cardiovascular disease. 39% or 40% were at high risk, and 60% were at very high risk. So there was nobody who was having a low risk. So clearly indicating that we have a clustering of cardiovascular risk factors right from the onset of diabetes. We need to be more careful in terms of proper management. In terms of seeing that our patients are maintaining the glycemic goals, and also managing the other risk factors like hypertension and lipid abnormalities being managed effectively so as to prevent the complications in our population, because we have a very high risk of cardiovascular complications in our population. So there were close to about 2 additional cardiovascular risk factors being present, and when you look at the Q score of our patients at onset of diabetes, we find that they had a 15.3% risk for development of amongst the females, and 13% risk amongst the males for a 10-year risk for developing cardiovascular disease, clearly showing that this is a very high risk for cardiovascular disease in our population. Interestingly, if you look at this Discover study program, this was looking at the HbA1c across the globe, and what we find is that although we have all this information, not only about one-fourth of our patients are at maintaining the glycemic targets that we are looking for, and majority of them are not able to achieve their glycemic targets. Not only in India but across the globe this is happening. In India also the scenario is bad, and therefore we need to work towards improving this and seeing that more of our patients are able to achieve their glycemic goals. What are the challenges? The challenges can be physician related. We may not be adopting a treat to target approach, which is now what we want to do is that we want to keep our patients at target rather than going stepwise by allowing them to first try out lifestyle measures for several months. They may not come back again, and then we start with one medication that is not enough, and then after a few months or few years we add another medication. So instead of going by that traditional approach, it is better to adopt a treat to target approach. Then medication related issues may be there, because single agents are not able to keep the patient at target, as we have seen, because we have different forms of therapy available today. We have metformin, we have the DPP-4 inhibitors, we have SGLT2 inhibitors. So in our first patient which we saw, some of us would have liked to get him to target by using 3 drugs rather than starting with a single drug like metformin alone, because the HbA1c was very high at onset itself, and it is but prudent to start with more therapies and get the patient to target and keep him at target rather than going by a traditional stepwise approach. Then there are other issues. Patients are concerned about the cost and complexities of therapy. They may be given advice by many other people around them that diabetes is a mild disease which does not require so much of therapy, and those are all issues which we have to tackle. And for that we need to comprehensively provide education to our patients. what we call it as diabetes self-management education is what we should provide, which helps in understanding the disease process, understanding the risk for complications, and how they can prevent these complications by lifestyle changes itself, which are effective in terms of getting them to their goals. So this is what is important, and early use of combination therapies is important. So here, this same study, the Discover program which I spoke about, which showed that the scenario is very grim across the globe. What they saw is that they looked at almost about 10,000 patients, and they looked at the proportion of patients achieving HbA1c less than 7% over 3 years was better in the group that was early intensified. That is 3,000 patients who were undergoing early intensification, that is using more than one therapy early in the course of diabetes, were able to achieve the goal as compared to those who followed the therapy, who followed the conventional approach of late intensification. So early diagnosis and timely intensification of glucose lowering treatment is important for achieving long-term glycemic control and improving the clinical outcomes. So, interestingly, I'll just quickly show you two studies. This is the Verify study, which looked at starting off treatment with metformin plus vildagliptin as compared to metformin alone. When they compared these two groups, what they found was that those who were started with metformin plus vildagliptin, they could be in control for a longer period of time. They could achieve control and maintain control for almost 5 years as compared to only 3 years of control being maintained with metformin alone. So starting a combination like this can help the patients in being in control for a longer duration of time and providing them that early glycemic benefit, which gives them a long legacy of protection from complications. So that is the important message that comes out of this Verify trial. And in that same trial, it was seen that those who were treated with the combination therapy had better preservation of their beta cell function for a longer duration of time as compared to those who were on initial monotherapy. So clearly you have benefit in terms of better glycemic control for a longer period of time. Even improvement in the beta cell function is there for a longer period of time. DeFronzo et al., who is very popular for his ominous octet which is described, he has looked at a study. He has done a study where he has looked at triple combination of metformin, pioglitazone and exenatide right at the onset of diabetes as compared to using again a stepwise approach with metformin alone. And in this study called the EDIC study, they have shown that early use of triple combination leads to better achievement of a glycemic goal of less than 6% can be achieved with a early use of combination therapy. Same has been, and they have shown that those who were on early combination therapy had better protection in terms of their complications. They had progression of their carotid intima media thickness was measured, and it was shown that it was slower by 50% over 5 years of follow-up. They did follow-up for 5 years, and they showed that they had this protection for about 5 years. A similar study was done by our own colleagues, Dr. J.J. Mukherjee from Calcutta. He looked at a triple combination, trying to see not looking at the complication, but trying to see the number of people who are able to achieve the glycemic target, and they also showed that early use of combination therapy led to better achievement of targets in more patients as compared to using a stepwise approach. There's another study which has looked at using metformin, dapagliflozin and saxagliptin. This is a Korean study which again showed that over 2 years of follow-up, they found that those who were started off on triple drug therapy right from the onset of diabetes had better control, better glycemic control and better improvements in terms of their beta cell function and also weight reduction with the use of this combination. So what I would like to highlight again from all this data that I have presented is that the first year of diabetes, the management during the first year is very important. It lays the foundation for long-term health benefits. It leads to establishment of healthy habits. It provides, and we should, if we are able to provide comprehensive diabetes education, psychological and emotional support to our patients, that leads to better control of diabetes and better management of all the comorbidities of diabetes, and gives them a good legacy for a lifetime which is free of complications. So I think this is important to achieve the goals of one of our, founding fathers, fathers of diabetes in India, Professor M. Vishwanathan, on his 100th anniversary, we remember him now, and he said long back before his, he has said that every person having diabetes should be helped to live his normal lifespan in perfect health. And that can be done by, early initiation of treatment, effective management of diabetes, and looking at all the comorbidities and providing them this benefit. So the take-home message I would like to give is, establish the diagnosis of diabetes early. Do not give the label of mild or borderline diabetes that makes the patient complacent. Start treatment early. The first year of diabetes is the golden year, which gives your patient a good legacy of complication-free life. If you are able to get them to a goal of less than HbA1c of less than 6.5%, you provide them a legacy of a good complication-free life, and provide complete treatment of diabetes. Not only manage their hyperglycemia, but manage the other comorbidities like hypertension, dyslipidemia, and motivate your patients for regular exercise, medication, and monitoring therapy. And this will go a long way in doing what we are speaking today. Dr. Jayant Panda has said that he has chosen this theme for this conference today of making India diabetes free, and that can be done. That is a difficult task. We know that diabetes is a common, costly, and serious disease, but yet controllable. Managing diabetes is easier than managing the complications. Success is difficult, but we should never ever give up. Just like this frog in the mouth of the crane, still not giving up. So like that, we also should continue to provide better care for our patients and see that they are having a healthy life which is free from the complications. Thank you all.
Thank you, Professor Sahab, for your most simplified and the lucid deliberation that we have ever had. And the RSSDI Odisha chapter, under the chairmanship or leadership of Dr. Jayant Panda, will be obliged to you for accepting our invitation to deliberation for the Siddhartha Das, most prestigious Siddhartha Das oration. At the outset, at the last, I will request all my delegates to have a standing ovation to Professor Siddhartha Das for his dedicated work in diabetes.
That Siddharth should be now healthy and should have a speedy recovery so that he joins us and becomes a regular part of the conference.
Thank you, sir.
Thank you.
Thank you to the chairpersons and the orators for smoothly conducting the session. Now we are on the penultimate session just before the inaugural ceremony, and it's the RSSDI ODISHA oration. And let's welcome the esteemed chairpersons of the session, Dr. M.K. Chotrai, Senior Consultant of Medicine, Apollo Hospital, Bhubaneswar. May I request the chairpersons to please be seated in their respective seats on the dais, please. Professor S.R. Patnaik, Professor and Head of Department of Endocrinology, SCB Medical College and Hospital, Cuttack. Dr. Kartik Chandra Raut, Senior Consultant of Medicine, Jajpur. Now we have with us Professor Dr. Namita Mahapatra, Professor and Head of the Department of Medicine, PGIMR and Capital Hospital, Bhubaneswar. I request all the chairpersons to please be seated on their respective seats on the dais. Sir and Madam, please. Now my sincere request to the orator of the session, Dr. Anuj Maheshwari, Governor, American College of Physicians, India Chapter, to join us on the dais. Sir, please. Now, may I request the chairpersons to honor Dr. Maheshwari with the felicitations. Thank you, everyone. Now it's up to the chairpersons to lead the session. Thank you.
Thank you, ODISHA RSSDI, for showering your love and affection on me one more time. I really wish to say it here that I have got a special attachment with Odisha, people of Odisha. Last year, Dr. Shotre has also invited me for the RSSDI API you did at the Raurkela, where I got an opportunity to speak on oration here and RSSDI also, which is my own organization. Overall, I have worked since from the very beginning to the end, and still I shall be keeping on working for the RSSDI. So it's my really great pleasure that I have been invited here and I have been given an opportunity to interact with you regarding a very important topic, that epidemiological diversities and management challenges in type 2 diabetes in India. What do we see since from the morning? Dr. Jain Panda has taken us to revisit down the memory line at the organizational level of the RSSDI. What did the RSSDI do in last 7-8 years from the point of view of the Odisha? After that, our respected president, Dr. Sahai, has told us what is the reality at present in the diabetes management and what do we really need to do for the diabetes management. I am taking you to a completely different perspective towards the diabetes management, especially which is more important for the Indian perspective. Whenever we talk about the diabetes management, most of the time it is the treatment related, most of the time it is related to the population which are being covered by the Western guidelines like ADA, EST. Now the RSSDI has started issuing its own guidelines since 2015. In Lucknow it has been first time disclosed and first time issued. And what is more important in Indian perspective, that is to focus on the epidemiological diversities. India is a country which is full of diversity. We can see diversities related to the geographical area, diversity is related to the food, diversity is related to the daily routine, diversity is related to the income, diversity is related to the gender, and diversity is related to the social class, and as well as now Dr. Rakesh has highlighted that diversities are there which is age related also. Diabetes is performing very much differently when it is on the early age and when it is on the higher age and when it is on the middle age. So this is its burden which is going to be, hope it may not close. So it's a burden which is going to be changed day by day, and we all know that we are expecting 783 million patients with diabetes in 2045. Its burden and its prevalence is steady rising in India. What do we see that in 2000 we were 32 million only, and now in 2020 we are 101 million only. So in last 20 years, the prevalence has increased almost 3 times, more than 3 times. So this is a big rise and very sharp rise, and which is not really expected. We did not grow that much in our inflation. We did not grow that much in our population. We did not grow in other perspective, but we grown much in the occurrence of the diabetes, in the prevalence of the diabetes. So what do we understand when we talk about the epidemiological diversities? It is actually the variation in the pattern, causes, and effects of health conditions across different populations, different regions, and different time periods. When we talk about the epidemiological diversities, it is not only the geographical diversity, it is also the population-specific needs which may be different. In Odisha, there may be some different needs than Uttar Pradesh and Maharashtra. In Bengal, there may be some different needs than other countries. Another, our focus should also be on the reducing the health disparities. Many a times, the health facilities are not similar in all parts of our country. Somewhere we are accessible to the diabetes management easily, and somewhere it is very difficult. In some of the states, we have provided the glucometer to the primary health care and Anganwadi worker as well as Asha worker, and some of the places, even patients are not knowing about the glucometer, what are they and how do they work. Resource allocation may be different, and all these having the impact on the policy development. At the same time, policy development also plays an important role, keeping the resource allocation appropriately to the all geographical area in all the population areas, and all population needs to be fulfilled well. So sometimes these disparities which can be corrected and should be addressed maybe on the basis of the demographic, like age, gender, ethnicity, socioeconomic status, may be related to the geographical area. Sometimes they are also related to the genetic factors. Some people may be genetically different, that's why they may be more prone to develop type 2 diabetes and insulin resistance. Some people may be having some different cultural habits or behavioral habits because of what they may develop diabetes more commonly. Socioeconomic factors also plays an important role, like income, education, occupation. They all have an impact on the occurrence of type 2 diabetes, and not only on the occurrence, but how successfully we shall be managing the type 2 diabetes, that is also determined by all these factors. Let's talk about the demographic factors. We see that middle-aged adults and older-age adults are having the different priorities. Dr. Rakesh Sai has very nicely explained in one of his slides that how do the prevalence of diabetes is different in the early age onset diabetes and the adult age onset diabetes, in the elderly people and in the young people in India. Now, we all know that older people were having the higher prevalence, and complex management were there because of the age-related challenges. Older people may be having different response related to the medication, related to the acceptance of the insulin, related to the many other things which are important for the diabetes management. So there may be the challenges in adhering to the medications and lifestyle modification. But these kinds of the challenges are usually not seen in the middle-aged adults. They can easily be accepting if they are well aware, if they are well educated. There is the need of the balancing work, family, and diabetes management. Most of the time, in their hush of work, food, earning, diabetes management lost somewhere. People just forget to take the medication whenever they are busy throughout the day for their livelihood and for their earning. Genders also plays an important role whenever the diabetes is concerned. Very rarely we focus on this issue that females may be performing differently than their male counterpart as well as far as the diabetes management is concerned. We all know about that. We all talk about that females are having a different hormonal status, a unique kind of the hormonal status, especially in their reproductive age group. Because of that hormonal status, during the reproductive age group, they are kept away from the cardiovascular adverse outcome up to the larger extent. But once the diabetes enter into the profile, that cardiovascular adverse outcome comes back. which have been kept by the nature away from them, they are there. When we are living with the lifestyle which is associated with the abnormal day routine, which are associated with the alcohol, which is associated with the abnormal time food, fast food, which is associated with the physical inactivity, which is associated with the tobacco consumption, then the things becomes quite different even in the female's life also. And because of their unique kind of the hormonal status, diabetes management becomes different with the menstrual cycle. In the some days of the menstrual cycle, hypoglycemia is more common. In other days of the menstrual cycle, hyperglycemia is very commonly seen. Similarly, we see the racial and ethnic disparities also in our population, which could be seen with the higher prevalence and earlier onset in certain ethnic groups, like groups which are involving the population, African American, Hispanic, and Native Americans. But in Asians, all are having the higher prevalence, all are having the tendency to develop the earlier onset of the diabetes. And of course, they are more prone to develop the diabetes because of their genetic predisposition and cultural and dietary habits which are prevalent in India. Like all India across, carbohydrate eating is the commonly seen. We all are mainly carbohydrate eater, and when we are not doing the physical activity as much as we are eating, obviously we become more prone to develop the diabetes. So these are the disparities in access to healthcare and adherence to the treatment which determine the occurrence of diabetes and prevalence of diabetes, as well as the how did the management will go for the diabetes. Here we can see the certain risk factors and certain predictors are there which decide that which person will develop diabetes and which person may be kept away from the diabetes, like BMI. Since from the very beginning we see that our kids are developing higher BMI, higher level of the testosterone and lower level of the estrogens in female, lower level of the testosterone in male. Waist circumference is important determinant for the type 2 diabetes. Similarly, the visceral adipose tissue, NAFLD, has been identified recently, including the PCOS, as the determinants of the type 2 diabetes. And very rightly, few years before, DIPSI has also declared that GDM is one of the determinant of the type 2 diabetes. So if we can stop GDM, if we can control GDM, probably we can stop the mother to become type 2 diabetes in next 10 years. 50% females, those who develop GDM, they develop type 2 diabetes after 10 years of their first pregnancy with hyperglycemia. A lot of clinical features are also determined with the genetic factor, with the epigenetic factors, and many of the time the habitual things what we see in our day-to-day life, like impaired fasting glucose, impaired glucose tolerance. They also differ depending upon the gender, depending upon the age of the patient. Many a times we see that young people are quite reluctant for their treatment, but actually that is the right time when we should focus and we should push them towards the tight control of the hyperglycemia. Psychosocial factors also plays an important role in the diabetes and its control, getting uncontrolled as well as getting control. Whatever way we can see that psychosocial factors remains in the, stress factors remains in the background always. Complications also depends upon, we all know, whatever would be the management of the diabetes, that would also determine how early the complications will come up. But apart from that, there are certain racial differences, there are certain genetic differences which determine that this geographical area is more prone to develop the kidney diseases, another geographical area is more prone to develop the cardiovascular adverse outcome, and some areas are not really developing that much of the complications despite having the severe hyperglycemia. Therapeutic preferences also can be decided depending upon these geographical priorities and these geographical differentiations, if we can really recognize and identify them in the real perspective. In general, men have greater insulin resistance and higher fasting glucose level and higher visceral fat mass than women. However, visceral adipose tissue may be determined by the waist circumference as a marker of the central obesity, appears to be a better predictor of the insulin resistance and development of type 2 diabetes and CVD in women than in men. In women, CVD risk factors like obesity and hypertension progress during menopausal transition, further aggravating insulin resistant inflammation and dyslipidemia in the later part of their life. At type 2 diabetes diagnosis, women often show larger excess weight gain, higher levels of the obesity as well as higher blood pressure than men, presenting with an overall higher cardiometabolic disease risk factor burden. So diabetes and ethnicity also plays an important role. People of the Asian ethnicities are more prone to develop 2 to 4 times more likely to have diabetes than white population. Combined effect of the genetic and socioeconomic risk on the prevalence of the type 2 diabetes, when it combines with the obesity, it becomes greater and greater. What we could see it here in this picture, that socioeconomic risk factors are determining the occurrence of the diabetes, but once it is combining with the obesity, once it is combining with the higher BMI, we can see this takes us towards the sharp rise to the 22.2% of the occurrence. The socioeconomic and genetic factors likely interact in an additive way to affect people's risk of developing obesity and type 2 diabetes. Interventions which can be done to improve socioeconomic deprivation may decrease metabolic diseases at the individual and community levels, especially among people with concomitant high genetic risk. Results indicated that people in the highest quintile of the both genetic and socioeconomic risk had a more than 7-fold higher prevalence of the type 2 diabetes and a more than 3-fold higher prevalence of the obesity compared with those in the combined lowest risk quintiles. And it has been well noticed that children born with the low birth weight are more prone to develop diabetes in their later life. This has been well established fact. Not only the macrosomia, but the low birth weight children are having more prone to have the diabetes and metabolic diseases. Let's talk about the few of the difference between urban and rural. Higher access to the healthcare facilities in the urban, people remains on the benefit, availability of the diabetes education, their control program, resources, increased availability of the healthy food options. I don't know how much healthy and how much unhealthy is there. This is also debatable what is available in the urban area. What is available in the rural area can also definitely be sometimes more healthy as compared to what is available in the urban area. But of course, the access to the healthcare is definitely better in the urban area. Number of people with diabetes in adults, which are ranging between 20 to 79 years living in urban and rural area in 2021 and 2045, you can see it here that, in 2021, this difference is there, which is going to be 2 times or 3 times in 2045. So urban area is definitely going to be growing more fast as compared to the rural area. Environmental and socio-economic factors, if we talk about the climate, weather conditions which are affecting on the physical activity, pollution and its impact on overall health and diabetes management, geographic isolation leading to challenges in accessing healthcare. Northern part of the country is suffering these differences and these challenges of the weather change and highly cold weather and highly hot weather, which may stop their movement, which may reduce their physical activity. But still we see that diabetes is less common in those areas as compared to the southern population. As far as our studies in diabetes studies and whatever the studies are there, they say that northern areas are having lesser prevalence of the diabetes as compared to the southern India. Similarly, areas with the lower socioeconomic status often have higher rates of the type 2 diabetes. Financial barriers to access healthcare and purchasing necessary medication and supplies are definitely determinants for the type 2 diabetes. And variation in the health literacy, awareness of the diabetes management directly impacts on the control of type 2 diabetes. Lot of environmental factors are also playing its role, like pollution, weather, climate, what has already been discussed. Type 2 diabetes disease burden increasing globally, but low and middle income countries like India showed the highest growth rate. A high BMI level remained the key contributing factor in all income tiers, but environmental and lifestyle related factors contributed differently across the income tiers. So health, as far as the regional healthcare disparities are concerned, we can see the variations in the quality and availability of the healthcare services across the region. We see that public health policies may be made which have the impact of the regional health on the diabetes prevention and management program. Differences in the insurance coverage and affordability for the diabetes care, again, the status in India is very much different. Even the day care is not covered with the insurance policies and insurance scheme. Only the hospitalization is covered. That's why everybody wants to be hospitalized so that he can get the benefits from the insurance scheme. Availability of the community support groups and diabetes education programs are really not that much as much they should be there, and impact of the local government initiatives on promoting health lifestyles could be highest, but which is not seen. RSSDI kind of the organizations are making such kind of the initiative. Government is taking the least in that direction. So according to the data published by IDF in 2019, 43.9 million people with diabetes are undiagnosed in India because of the poorly developed healthcare system. The number is quite alarming from an Indian perspective, as the progression from the pre-diabetes to diabetes occurs much faster in the Asian population than in any other ethnic population. ICMR in Phase 1 reported that only 43.2% of the population were aware of the diabetes, and the level of awareness was significantly low among rural residents compared to urban residents. 36.8% in the rural areas and 58.4% in the urban areas was the level of awareness among the residents. Treatment expenditure burden, like logistic issues for the patient living in rural setting, underdeveloped public health care infrastructure, and unavailability of the anti-diabetic medications may contribute to the higher rate of the unknown to known diabetes ratio and mortality rate in rural area. Lack of trained diabetes educator in India not only increase the burden on physicians to educate patients, but also leads to an increase in the incidence and prevalence of type 2 diabetes. It is also documented that dietitians in India were generally unfamiliar with the details of the process used to identify, evaluate, and synthesize the research into the guidelines. And it is really very much important aspect which is to be noticed by all of us. To talk about the genetic factors, obviously the family history, certain genetic variants in the population are responsible for occurrence of the type 2 diabetes in one area, despite a lot of challenges and despite not that much challenges. So genetic predisposition and risk factors, what we see, they are mapped on our India, that these are the genetic predisposition what we could see. And this is actually associated with the occurrence of type 2 diabetes with the single nucleotide polymorphism. Here you can see the area which is being covered by the largest circle is covering the population which is affected by multiple genes which are having its impact on the insulin secretion, insulin resistance, BMI, their body weight, growth, and IGF factors, and a lot of other things, the liver fat also. Similarly, what we see in East Asians, the genetic risk score is really more and more sharper as compared to the rest of the world. Here you can see what is the East Asian, that is the green line is reflecting the East Asian situation, which is followed by the American Indians, which is the purple line, and rest European and African are coming later to this. So lifestyle choices, physical activity is the choice which can never be forgotten. If it is being forgotten, definitely you cannot stop the diabetes. Sedentary lifestyle increases the risk of type 2 diabetes and its complications. Cultural norms may limit participation in physical activities, especially for women in certain societies. They are kept inside of the house, and that again restrict their physical movement. Dietary habits, certain societies and certain religious preferences may not be allowing the high protein diet to many of us. That also has an impact on the occurrence of diabetes and management of the complication. Socioeconomic factors like access to the health care, healthy lifestyle, health literacy, and diabetes education program, they are playing an impactful role in the management of the type 2 diabetes. So once we talk about the poverty, it increases the type 2 diabetes incidence and inequality of care despite universal health coverage. So less food, less money, lower income group, more of the poverty are being the determinant in India for type 2 diabetes nowadays. Occupation related challenges like work environment, occupational health support, how much you are getting your medical bills reimbursed from your employer, how much you are getting good quality of the food, and how much stress you are having at your workstation or work environment. That is most important, and they are determining the occurrence of the diabetes. Now question arises, what could be the strategies and management? Community-based programs are the one of the important strategies which could be included. Like they have the importance of the community support when we look for the strengthening social network, leveraging the families, friends, and community groups to support diabetes management. Most of the people are living in the nuclear families, they are living in the larger cities alone, and they are really finding these things are lacking. Education programs should be implemented across the country related to the diabetes awareness, and this should be implemented at the school level when we tell our students that they should be aware of the control of the diabetes and its methods of management. And community-based programs which are already running, but most of the time they are running by the societies like us, not by the government much. Strategies for the policymakers can be made which can improve the access to the healthcare, expand healthcare coverage and reduce financial barrier, increase the availability of the diabetes care services in underserved areas. There we can promote the health education again by multiple ways, by making the policies like the school syllabus, school education, include the diabetes in the syllabus, supporting the research and data collection which is very much needed in our country. Our country is having a lot of patients, millions of the patients, but collection of data is very poor because of what we are not able to publish the results of the research. Fund research on the epidemiological diversities and their impact on the diabetes management can be done by the government also, but presently it is being done by the RSSDI and such kind of the organization. We can enhance the data collection system to monitor diabetes trends and evaluate the intervention outcome. We can definitely have the policy initiative and can give the examples to the policy maker to subsidize the diabetes medication supplies for the low income population. We can ask them to establish the national diabetes registries to track and manage the disease more effectively. Thank you very much for your kind listening.
Thank you, Professor Maheshwari, for that informative talk. Dr. Maheshwari is not only past Vice President of RSSDI, he is associated in all the associations, name it API, name it RSSDI, or any institution. Last year we had invited him to API at Raulkela, and also he managed our national annual conference at ODISHA, American College of Physicians annual function. Every time you call him, he gives his consent, and with a smiling face, he manages the show. Thank you, Professor Maheshwari, for taking interest in our functions. Thank you again.
And Professor Anuj, in a very short while, you have told the whole house about the whole aspect of diabetes, beginning from racial, genetic, geography, and ethnic factors to genetic and environment. And you have touched, not only you have given the topic of diversity of epidemiology, but you have touched everything in the diabetes. In a short while, you have taught the whole house about the whole aspects of diabetes. Not only in teaching the house or speaking the house about disparities, but you have also told about how to improve the socioeconomic status and how much socioeconomic status influences diabetes and its control. And the one thing that that we learned from your lucid talk, that creating awareness in the society is main factor for this. At the same time, there must be training for not only medical personnels. The training should be also comparted to the paramedics and persons who are there in the affiliated to diabetes care. So diabetes care can be dealt with only very efficiently if such people are brought to picture and given proper trainings in right time. And that will definitely be helpful. And I am very thankful to you that you have touched everything in this. Even the socio-economic status, the genetic, and everything has been so nicely described. And it will definitely be a good take-home message for everybody. I think everybody should agree with me that these topic, such type of topic with a large coverage should be presented in such type of forum. Thank you very much. So let us close this session.
I thank the chairpersons for chairing the prestigious RSSDI Odisha oration. I thank the orator, Professor Anuj Maheshwari, Governor ACP India chapter. He has given a very important message which all of us should learn to practice. In 5 minutes time, we are starting the inaugural function where there will be a formal felicitation and formal inauguration of the conference by our Honorable President RSSDI and Governor ACP India chapter. There are chief guest and guest of honor. I request you to stay back, and there are a few housekeeping announcements by the time the stage is ready. We have post-lunch sessions divided in 2 halls. Program will continue in Hall A, but also in the Hall B, first floor, we have program. And besides that, there is program in a virtual room where important faculties have also joined. That link also I have shared in RSSDI group, in faculty group, in Puri group. So you can join virtually for any session you are interested. We have around 12 sessions virtually. We have Hall B program, we have Hall A program post-lunch. Lunch will be shortly started and lunch will continue parallelly when the scientific programs will go on, because we are almost 1 hour late. We are not breaking for lunch. So please take shortest time, say 15 minutes, have your lunch and come back. Lunch will be starting shortly. And the good thing is that the conference bags are ready. From yesterday, many people are waiting for the bags. That's a very useful bag, handy bag that has reached. And your pad, pen, bag, and also spouse bag are ready in the registration counter. So those who break for lunch, collect your bag and you can come back to hall. Don't make a big rush. Phase-wise, I think it will be distributed to all of you. Those who leave early or have other engagements can collect it early. I thank all the national faculties who have joined. I see Ajay Tiwari ji has joined, and Bharat Shabu ji has joined, and Akash Singh is there, and Shambhu is there, Dr. Shambhu Datta, and then all Arun Kedia is there, and then Shaival Goha is there. So we welcome all our invited faculties. There's a huge number of registrations, and I'm sure you'll enjoy the second half program also. We had a prestigious plenary session including keynote lectures and the orations, and the second half will have very interesting, useful sessions which are conducted in 2 halls and 1 virtual room. And it's expected that by 6:30 we'll be completing our scientific program, and 6:30 to 7:30 is the GB meeting in Hall B. Those who are members of RSSDI Odisha are invited to know the next conference venue and the other formalities of the organization between 6:30 to 7:30 in Hall B. And from 7:30 in this hall, we have entertainment program and dinner outside. This is the program for today. And tomorrow again we have 2 halls. Here the program will go on, and the Hall B will host the pre-paper session of those who have presented the pre-paper, and will be doing a platform presentation, followed by a postgraduate quiz. We have very interesting prizes, cash prizes for both free paper and postgraduate quiz. And Professor Shrikant Dhar is the quiz master for the postgraduate quiz, and Professor K.P. Tripathi and also Professor Chandan Das will be conducting the free paper session tomorrow. This is for the postgraduates. With this, if the stage is ready, it's over to our anchors, Anshuman and Asha. Thank you all.
Hello, hello. Settle down. Everyone, please kindly settle down for the inaugural ceremony. A very hearty good afternoon to everyone present here. Myself, Asajyoti, host of the event, and by my side, my co-host, Ansuman.
We welcome you all to this inaugural ceremony of the 12th Annual Conference of Research Society for the Study of Diabetes in India, RSSDI, Odisha State Chapter 2024.
Before starting the program, let's revisit the history of RSSDI. RSSDI, the society, was founded by Dr. Manmohan Singh Ahuja in 1973, the largest body of professional doctors and researchers in Asia, working in the area of diabetes, and the national body recognized by the International Diabetes Federation, IDF.
And today, we are celebrating its remarkable achievements and future endeavors. On this 12th annual conference, we all have our invited speakers who share knowledge from their experience to the delegates in a practical way.
Yes, we are all gathered here to work towards a future where Indians, in fact the world, can live free from the shackles of diabetes and its complications.
Our active participation will make this event a grand success by taking home the message, let's de-diabetes India.
Named personalities of this inaugural ceremony, we are privileged to invite a renowned authority of our today's chief guest, Professor Dr. Rakesh Kumar Sahaya, President RSSDI, Professor and Head of the Department of Endocrinology, Nizam's Institute of Medical Sciences, Hyderabad.
I am immensely gratified inviting an eminent clinician, our guest of honor, Professor Dr. Anuj Maheshwari, Governor of American College of Physicians, India Chapter. Sir, please.
It's my pleasure to invite a distinguished and expert clinician, Professor Dr. Jayant Kumar Panda, Chairman, RSSDI ODISHA, onto the dais. So please adorn the dais.
Let's welcome a highly acclaimed physician, Professor Dr. Uma Shankar Misra, Chairman of the Organizing Committee. Sir, please join us on the dais.
It's our distinct privilege to invite Professor Dr. Kaushik Mishra, Co-Chairman, Reception Committee. So please, grace the dais with your presence.
It's our honor to cordially invite Professor Dr. Ramesh Kumar Goenka, Chairman-elect RSSDI.
Now let's extend our warmest welcome to Professor Dr. Sambit Das, Chapter Secretary, RSSDI, Odisha.
We are delighted to invite Professor Dr. Santosh Kumar Swai, Organizing Secretary, RSSDI, Odisha.
Thank you, everyone. Now, I request everyone to stand in respect and honor as we play the state anthem. Everyone, please.
Vande Utkala Janani, Vande Utkala Janani, Vande Utkala Janani. Charu bhasamai, Janani, Janani, Janani. Vande Utkala Janani. Bhuta payoti vibhauta sarira, Tadata mada susobhita tira, Suprakatini kula sikara samira, Janani, Janani, Janani. Vande Utkala Janani. Sundara mandira mandita desa, Charu kala badi sobhita besa, Punya tirtha jaya purna pradesa, Janani, Janani, Janani. Vande Utkala Janani. Kavi kula mauli sunandana bandya, Bhuvana vighosita kirti anindya, Dhanne punne chira saranye, Janani, Janani, Janani. Vande Utkala Janani. Vande Utkala Janani. Vande Utkala Janani.
I request everyone to kindly take their seat. Ladies and gentlemen, it is our honor to have a visionary leader, the driving force, Professor Dr. Jayant Kumar Panda, Chairman RSSDI. I cordially invite Professor Dr. Jayant Kumar Panda to present the welcome address and embark the beginning of this mega conference.
Thank you. I, on behalf of RSSDI Odisha, welcome you all to this 12th annual meeting. And on stage, we have our invited guests, Professor Rakesh Sahai here. He is son of a legendary father, Professor B.K. Sahai, who usually blesses all of us and our friend, philosopher, guide. Manisha ma'am, Manisha Sahai, she is a professor of nephrology and part of the RSSDI Odisha family. So we don't feel that Professor Rakesh Sahai and Professor Manisha Sahai from the Sahai group, Hyderabad, or Professor B.K. Sahai family are not from our state. We have been interacting for last 30 years as part of the family. Please give a big hand welcoming Professor Sahai, who is at present is the President RSSDI National, and the RSSDI is glorified with him gracing the organization as the national head. He is a scientist with so many publications to his credit, and a faculty, a writer, a researcher contributing so many chapters to the books, and have been part of the partial of the guidelines and the activities in the field of diabetes and metabolic medicine as well as endocrinology for last 4 decades. And all of you know, he has showed Endocrine Society of India as president. He has showed many organizations like Shafi as president, and he has cancelled his Shafi program where he is the world head now to come to this program to participate in our oration and participate in our inauguration. Welcome, Professor Sai, to Holy Land of Puri, and we wish the blessing of Lord Jagannath will be there with you and family for all the time. We have Professor Anuj Maheshwari, again part of the family, and he has not disappointed us. The next week is the ACP India Chapter Conference, National Conference, at his own place, Lucknow, and he's packed with the works. You know, last week, how much work remains in a conference. But still, for a day, he has made it and graced our program, delivered the RSSDI Odisha oration, and also became a guest of honor of our inaugural function. Give a big hand for Professor Anuj Maheshwari, who again is part of the Odisha family whom we take since long. Besides our own family, Professor Umashankar Mishra is my teacher. He is a leading physician. At present, he is the head of medicine at Sri Jagannath Medical College, Puri, who has taken the responsibility of coordinating and hosting such a mammoth event. And Shar is the organizing chair here. Please welcome Professor Mishra with a big hand. We have Dr. Ramesh Kumar Goenka. We'll be felicitating Dr. Goenka along with our treasurer, Dr. Shandip Devashish Mishra, for serving the organization right from the beginning. And he has done a mammoth work watching the organization at every front, the financial front, the CME front, the conference front, and the participation at the national and the state level. Say it a research retreat, say it a national conference, say it a coordination between state chapters. Dr. Goenka is always there, and he is a leading diabetologist of the state and a organizer for excellence with a huge commitment towards the organization. And I'm sure I'll be giving responsibility to such a able hand, and he'll take care of the state RSSDI for the next term as chairman. Give a big hand for Dr. Goenka, who has been a face of RSSDI in last 12 years. Welcome, sir. And we have Professor Sambit Das. All of you know him. He is the Vice President of the Endocrine Society of India, and the Endocrine and Diabetes Update, EDU, that he hosts is a popular annual event attended by many national faculties. He has showed in high tech, showed in Apollo. At present, the professor head endocrinology of KIMS Bhubaneswar. He has been a popular teacher, encouraging science and research, and is there in our organization from the beginning. Such a able hand has taken the responsibility of RSSDI Odisha State Chapter. I wish he continues as the secretary for at least 2-3 terms, not only this year, and welcome Professor Shambit with a big hand. Finally, I'll tell about two people who belong to this place and taken the responsibility and unable to sleep for each sponsorer, for each faculty, for each delegate, from bag to food, from inauguration to CME, from workshop to valedictory. They are running as if it's a personal function, marriage of their daughter, and that is needed for hosting a conference. We have Professor Santosh Swai here. Give a big hand, who has been not in RSSDI only, but API, CCDSI, Geriatric Society. You say any organization is incomplete without Professor Swai. And even in Sri Jagannath Medical College, the service of the medicine department and the students teaching and the patients welfare are put by Professor Uma Mishra sir, and also Professor Santosh Swai sir's leadership. So I thank Professor Santosh for taking the responsibility, choosing such a nice venue, inviting the huge gallery of invited speakers, arranging such good food and ambience in front of the sea, and taking all the pain to make our each and every delegate happy. I welcome Harivallabh Mahapatra on stage. We have his chair vacant, and he is the co-organizing secretary from this place only. And with his commitment, his involvement, he has also contributed immensely to the conference. So finally, with this invitation to all the delegates, this invitation to the office bearers and the organizers of the event, I salute our national faculties for taking their time, busy time. You see, now every weekend is something, and day will come. Every day there will be something. I see programs are gradually shifting to the working days from the weekend. Now they have started it because the weekends are not free now. So they are coming to Mondays, they are coming to Thursdays, and all of them will agree to me that life is becoming very hectic. And in that, making this possible, Professor Akhya Pradhan, Professor of Cardiology in the KGMU, King George Medical University, Professor Shambhu Datta, he is a son of a soil, but was in the Navy and in the Visakhapatnam as a critical care consultant and metabolic consultant. We have Dr. Arun Kedia, Kalpana ma'am from the beautiful city of Raipur in the Chhattisgarh. We have Bharat Shabu here. We have galaxy of faculties from the state and many faculties who are in the faculty lounge for the lunch break. I congratulate all of them. I also thank my team member Dr. Sanjay Das, Dr. Satyanarayan Das, and the whole team, Sandeep Devasish, that whom will be felicitating, Lalatendu Mohanty, Uttal Khadanga, whole team, and Professor P.K. Mishra is here, whom will felicitate for lifetime achievement today afternoon. I invite you all, and with this, I request the anchor to take the program ahead. Thank you all.
Thank you, sir. Sir introduced many professionals. Actually, this is the event where there is association of many brilliant clinicians, physicians, and hoping it to be very enriching event for everyone, for all of you. Now, moving forward. Deepa Jyoti Param Brahma, Deepa Jyoti Janardanaha, Deepa Haratu Me Papam, Deepa Jyoti Namastute, Namastute, Namastute.
I sincerely request all the dignitaries to embark this event by seeking blessings from the Almighty and lighting the holy lamp. Sir, please.
radiance of this lamp spread far and wide, touching hearts and transforming lives. I request all the dignitaries to please be seated on their respective seats. Thank you. Next up, I'm gratified to invite an esteemed personality who is instrumental in the smooth coordination of this event, Professor Dr. Sambit Das, Chapter Secretary, RSSDI, ODISHA. My sincere request to Dr. Das to proceed with the Secretary's report. Sir, please.
Thank you. Respected Chief Guest Dr. Rakesh Sai sir, the guest of honor Dr. Anuj Maheshwari sir, Chairman Dr. Jayant Panda sir, and the distinguished dignitaries on the dais and off the dais, a very good afternoon to all of you. And at the outset, I must invite you to this holy city of Puri, where we are conducting the 12th RSSDI meeting, and it is a proud privilege for me to read out the Secretary's report for this year, though it's a very short stint for me because I just took over some 2 months back because Dr. Goenka got elected as the chairman-elect, so I got the memo task, and RSSDI Odisha was found in 2000 as Jain sir has told, and it was revived in 2013 by the able leadership of Professor Siddharth Das sir and Dr. Jayant Panda sir. And now we are at the 12th edition of RSSDI at Puri only. The total number of registered delegates for this conference has been around 900, and the footfall is going to increase further in the next 1 or 2 days, in the next day. The events which the RSSDI as an organization has conducted has...
But thanks to the hotel management, we found such a beautiful venue and with such a good facility, food and hospitality. We again thought of shifting from Cuttack and Bhubaneswar to Puri, and we designed the scientific program, and we are really thankful to all the national faculties who responded very nicely, and being guided by Professor Jayant Panda, we invited not less than 40 national faculties in this conference to deliver their expertise to all our delegates. We registered a record number of registrations during the event, and we have registered around 650 registrations from delegates and 200 spouses, almost the number touching, including the pharma participation, the number touching 1,000, which is a real achievement in the field of, to our organization. So RSSDI Odisha is growing very fast, and always it is again by chance or by luck of Dr. Panda that when he left RSSDI Odisha and headed for national, it was the conference at Puri, and when he again joined the association organization, he was requested to join the organization, and again he is doing under his leadership the conference at Puri. So I congratulate Dr. Panda for such an excellent conference, such an excellent show, and Lord Jagannath is really blessing on him that during his tenure only we see Puri again and again. And next year is the term of Cuttack as usual, but then our GB will decide next year where to go about. With this, I welcome you all to this scientific extravaganza for next 24 hours. Be with us, enjoy your science, and then in the evening, we will have some lighter moments. You will really enjoy the entertainment program and your gala dinner. In the morning, again we will have some science, and we will depart after the lunch. Thank you all. Long live RSSDI.
I do agree with sir that Jagannath Dham and the sea view and the mutual cooperation of all the faculties has added grandeur to this event. Thank you, sir. Thank you very much. Moving further, Without further delay, we heartily welcome Professor Dr. Kausik Mishra, our co-chairman, Reception Committee, to deliver his address. Sir, please. Sorry, he's not present. So we'll move further. With great pleasure, we introduce the chairman of the organizing committee, Professor Dr. Uma Sankar Mishra, who has led the team with vision and expertise. I'd like to entice Mr. Mishra to share his perspectives. Sir, please.
Welcome to all the delegates come from Odisha or from above other states, the dignitaries, the learned physicians all over India. Welcome to the holy place, the Puri Dham, the place of Lord Jagannath. My position here, before you, I am a professor of medicine in this Puri Medical College, Jagannath Medical College. I am Dr. Uma Sankar Mishra. My position is a bit ornamental, though I don't have any ornaments today. Everything has been done by Associate Professor Santosh Kumar Swai. So to tell something as a part of organizing the chairman, the organizing secretary has given me some lines to tell, but everything has been told by my predecessors. So nothing to tell, only thing, I welcome you all, wishing you a good luck, wishing you a good stay at Puri with a scientific extravaganza and also entertainment. Have a darshan of Lord Jagannath and Lord Lokanath, both Shiva and Vishnu, and enjoy the place. Thank you all. And lastly, I, as the organizing secretary, I declare the conference put into order. Thank you.
Thank you very much, sir, for your heartfelt wishes. Today, we gather to honor the exceptional individuals who have made outstanding contributions and felicitate them for their remarkable accomplishments. Now, I would like to invite our chairman, Professor Dr. Jayant Kumar Panda, and our chapter secretary, Professor Dr. Sandeep Das, to come forward to felicitate our dignitaries. I would like to invite Professor Dr. Ramesh Kumar Sahai, Professor Dr. Rakesh Kumar Sahai, our esteemed chief guest, and our guest of honor, Professor Dr. Anuj Maheshwari, to kindly come forward.
Felicitation for the lifetime achievement and extraordinary contributions to RSSDI ODISHA, Professor Dr. Prashant Kumar Mishra, former professor and head of the Department of Endocrinology, SCB Medical College and Hospital, Cuttack. He is the key person to establish the Endocrine Society of Odisha chapter. My humble request to sir to join us on the dais. Sir, please. Thank you, sir. Your contributions will forever be remembered in the history of RSSDI. Thank you very much.
Actually, Professor Mishra is a father figure. You help get this in the field of diabetes, and you'll be happy to know Professor Mishra is invited as a patron of RSSDI ODISHA along with Professor Siddharth Das in the AC meeting, and today GB will invite him. I request Professor Mishra to say a few words.
I have a two-digit life membership of RSSDI. And that was in 1980 when I was a dean student at PA Chandigarh. Next to it, that I was the organizing secretary of the National RSSDI, which was held here in Puri in 1982. And thereafter, I have seen those days when the number of the members of the National RSSDI was less than 60. Hardly 50 people used to come. And the rapid explosion, particularly after the demise of Professor Ahuja, it has exploded. And I think the number of members and the attendees for the National RSSDI is at par with that of API. And it becomes, I am really afraid of going to RSSDI then. And it is all the time a pleasure. And that with the problem of diabetic epidemic, global as well as our country, the orientation of the general physicians as the basic doctors with MBBS who actually handle the majority of patients with first 1 year of diagnosis. That is why I stress all the times that this fact should, or the science should go to that level with MBBS and MDs. We see only a few percent of the patients actually who deserve the help. So this message should actually be massive, and the undergraduate and postgraduate teaching in medicine, pediatrics, everywhere should be more expansive. The teachers who are now in medical college, particularly in Department of Medicine and Pediatrics, they must stress on the subject of diabetes. Not only diabetes, obesity, thyroid, which have become a problem of the country now. And it is a discipline where a positive treatment is there. You can give a quality and quantity of life with good treatment to so many ailing humanity. So it is really a pleasure that we see things growing on. And I had the pleasure of getting the RSS gold medal some few years back that was held at Ahmedabad. So that is what is my experience with RSSDI. But though I am not an active member of the society today, but there are now people around us who are really managing the show very nice. I bless you all, and I also bless the future of physicians in the field. Thank you.
Thank you, sir. I think,
yes. Thank you, sir.
I think everyone have beautifully continued the legacy of sir. And this event should actually be included in the MBBS curriculum to apt the future generations and prep up them. Thank you.
Next, I would like to invite Professor Dr. Abhay Kumar Sahu and Dr. Utkal Kishore Khadanga for successful hosting of the 11th Annual Conference of RSSDI in 2023.
Last year, we all were at Bhubaneswar Crystal Crown, and it was under the stewardship of Professor Sahu and the Utkal, our muscle man, and a man who exemplifies exercise in the real life. Yesterday we discussed in the workshop, there are very few people who do exercise, but a person who is committed to exercise is Dr. Utkal, and I request our guests to felicitate both of them. It was the event out of the box where almost 1,000 people were there, almost 1,000 people are there, and along with the beautiful banquet and the good signs with 30 plus national faculties. It was one of the very successful event they hosted. Give a big hand to the organizing team. And not only that, they have got their account audited and submitted their account just recently. So they have closed the account also, and the event had made a vibration all across the country and the globe. So congratulations, Professor Sahu. Congratulations, Utkal. I request Professor Sahu to say 2 minutes about the event, experience of hosting RSSDI 23.
Thank you, John sir. Thank you, the respected dignitaries and all my friends and colleagues. So last year, actually, 2 years back, Utkal actually planned ki we'll do RSSDI. Then he discussed not only with me, we discussed with whole team. John sir, Goenka sir, Sambit, everybody was there. We discussed. Then we planned that definitely we'll do, and we tried our best. In between, actually, John sir asked me how many faculties you can accommodate. So we, myself and Utkal, told that limit is yours. You decide whatever you want, where it is actually you can. So that actually almost every state of the country actually has last year actually participated, and faculties from every state of our country were there in last year conference. And this is not only Utkal and myself have done, it is the team effort what we have done, and we try to do whatever the things possible, we try to do that, and hope everybody has cherished the memories of last year RSSDI event. And I think definitely in future, this year also it is unbelievable one, Puri, this venue, everything is beautiful, and hope every year will definitely grow, and will definitely have a very beautiful scientific program along with all additional things what we can tell, and if Utkal can add.
Nothing more to add. It is always a team effort, and with the able guidance of Dr. Jayant Panda sir, Goenka sir, and all Sambit, Abhay Bhai, and rest all, it is always going to be a huge success. And even this year and even next year to come, RSA Odisha is always going to be successful. Long live RSA Odisha.
Hoping for both successful future endeavors, let's move further. Now, I congratulate Dr. Ramesh Kumar Goenka and Dr. Sandeep Debasis Mishra for successfully managing RSSDI from its inception and taking it to new heights.
Yeah, Dr. Devasis, come here. Since the day Odisha RSSDI started, this duo, Ramesh Kumar Goenka and Sandeep Devashish Mishra, they have become icon of RSSDI Odisha, because they feel for RSSDI, they eat RSSDI, they sleep RSSDI, and without this much of sacrifice, an organization cannot grow. Give a big hand to them. Really, they have done a lot of work and will be doing further, we are sure. I request Dr. Goenka to say a few words.
Thank you, Chairman, sir. I was working as a secretary RSSDI. The mammoth arrangement of today's RSSDI is the vision of Dr. Jayant Panda, which we have seen in 2016. Beyond all limits, He doesn't bother for financial or any kind of budget sort of thing. He doesn't have anything in mind. He has only one thing in mind, that program should be glamorous and should be appreciated by everybody. So beyond all limits, he does the program. And the difference between him and me is, I little bit go by the budget and also see that the program is glamorous and successful. So with all that vision, we have brought forward RSSDI from zero to a sustainable organization. Now the organization has some strength, and probably we can start some research activity financing the researchers. So in future, we will see that, like our national vision, we promote our state research and we promote the research papers from our young researchers. And in future, I will like to get advice from Dr. Jayant Panda how to go about it. Thank you all.
Thank you, sir, for your incessant efforts and contributions
Few words,
in
Devasis.
giving the shape what RSSDI today.
So, good afternoon, everybody, and all the dignitaries on the dais, friends. RSSDI Odisha. Nothing more to say. Long live RSSDI Odisha.
Thank you very much, sir. I would like to request all the dignitaries to kindly take up their seats. Continuing on, we cordially invite a reverend persona, the past Vice President, RSSDI, Governor of American College of Physicians, India Chapter, Professor Dr. Anuj Maheshwari, to articulate a few lines taking a trip down his memory lane. Thank you.
I think already a lot of said about the RSSDI, its growth, and especially the growth of RSSDI Odisha chapter. It is tremendous, and it has been visible. I have been witness for this growth for last many years. Almost most of the conferences I have been attended in RSSDI Odisha chapter, and RSSDI National Conference 2017 has